think it started recording automatically actually when I started it. So it looks like I got about 20 popping on.
Great.
25, 26.
Good morning.
Good morning, everyone.
We're all
Good afternoon, good evening, wherever you're calling from.
across
We're waiting for everyone to join. Just kind of refresh that to see, make sure I don't have any last minute. We have close to 100 attending. I have about 92, I think, registered. And obviously some people might have 2 or 3 people watching. So we probably have in excess of 100 people watching the webinar.
Thank you for joining.
We're just going to give it a few more minutes to see if we get some more attendees. Okay. And my chat. Can everybody see the screen? I got a few chats from hello. Hello from Pittsburgh. We got some people from Colorado. We have Texas calling in. We have actually people calling in from about 20 different countries this morning.
Wonderful.
There's someone from India. So I'm not sure what time it is in India. I heard from somebody from the Netherlands this morning that was connecting in. I think it was about 5 o'clock.
Wow.
There's someone from Belgium, Boston, New Zealand. They've got somebody from down under, Germany, Spain.
Wonderful.
We're up to about 60 people right now. Poland, yes, we have a family from Poland that wrote an article in the last newsletter, which was very interesting. We have Costa Rica, Los Angeles, Buffalo.
Thank you, Kathy, for organizing this get together. It's wonderful.
No, well, thank you guys. We want to thank the NIH for taking time out of their busy schedule on a Saturday morning, afternoon to speak with us. During COVID, it's been kind of a strange year. OAA was not able to host our conference this year, and virtually early in the pandemic, we weren't real clear on how to do a virtual conference. So this is not, a conference format. It's more, we're calling it a town hall, just because, it's more of an informal process, and our conference tends to be a little informal as well. But we were hoping, that the NIH could speak to a lot of families that typically would go to the NIH for the study, but hasn't been able to because of the pandemic, and other families that maybe have not had the opportunity to hear about the study and the research that's going on with MMA and PA. Is an exciting time for our disorders, and so we hope that you enjoy what the attendees are speaking about, and the questions are going to be answered at the end of the town hall. So in the Q&A, you're welcome to submit any questions throughout the presentations. We're choosing to probably answer those at the end, just because sometimes there could be multiple questions on the same topic. So go ahead and use your chat. If you're not familiar with the Zoom, it's at the bottom of your screen, the chat field there. Submit it to all the panelists or to everyone if you want everyone to see. They will either try to answer it live, and if there's a question that needs more information, they may include something in the chat field to answer your question, or try to respond back to you at a different time if we're tight on time. We're going to try to limit it to 2 hours, but they're committed to answer all your questions. And of course, we're going to have close to 100 people signed up to attend. And there's already a Q&A. Honey, you're already asking your questions. So we're up to 68 people so far. I don't know if we should go ahead and start, just because we want to keep on the timetable here so that we're not here all day. So welcome everyone. Welcome. I'm calling in from Minnesota, and we have lots of families calling in from all over the world. And so we appreciate you spending your time calling in and listening to our presenters today. And we also thank the NIH and our speakers this morning and our research team there. We would not be where we are with new treatments and for MMA and PA if it wasn't for this team right here. So I'm going to introduce our first speaker, which is Dr. Irene Manoli. She's a physician, scientist, and clinician associate investigator in the organic acid research section of the National Human Genome Research Institute at the NIH. She received her MD, PhD from the University of Athens in Greece, pursued a pediatric residency in the UK, and subsequently trained in genetics and clinical biochemical genetics at the NIH, Bethesda, Maryland. She joined Dr. Venditti's organic acidemia section team after her fellowship in 2009, where she follows over 250 patients enrolled in the NIH clinical protocol on MMA and Cobalamin disorders. And she also works with the MMA mouse models with the goal of understanding disease mechanisms and translating therapies from animal models into the clinic. And this, we welcome you, Irene.
Thank you, Kathy, and thank you everyone for joining, especially during these very challenging times with the COVID raging pandemic everywhere. We appreciate your time here today, and I have photos from all the speakers. The chief of the section, Dr. Venditti, who started this research back in 2004 with Jennifer Sloan, our genetic counselor and the molecular geneticist and scientist in our unit. And then I joined in 2009, Dr. Chelokov joined in 2015, and Christopher Jordan, our younger member, who is a pediatric and fetal cardiologist, who joined this year. And then our contact people and people our families meet first when they come to the NIH. Susan Ferry, our research nurse, who communicates with the families and delegates everything about their visit. Carol Van Ryzen, our very experienced pediatric nurse practitioner, and our current clinical lead, Samantha McCoy. Over the years, we have many young people training with us, and a large group of postdocs and young students who are trained in genetics and biochemical genetics, and work with MMA animal models to develop gene therapy and new therapies for your children. And Randy Chandler, who was again a very key member of the research group, has worked with Dr. Venditti all these years for these new genomic therapies that we will be talking more about today. So I'm gonna give some recent highlights and recent developments for MMA and cobalamin disorders, and try to cover some of the basic questions about what type of MMAs are there out there. There are all these many names, and what does it matter which exactly type every kid has? What will happen to the children, and how can we tell which of the children will be more severely affected or more milder affected? What are the different treatments that we employ, and what is the best treatment and diet for every kid? Who is a good candidate to get a liver or a liver and kidney transplant? What of type is the better one, and when is the right time to go forward with this big decision? And then why is it important to participate in research to help with the development of these therapies? We have to start with the pathways. MMAs are involved in the breakdown of protein in the food. So food has to be broken down inside our cells to produce energy. This is a complicated process. The special amino acids that produce propionyl-CoA, we have this acronym to remember them. VOMIT stands for valine, oat-chain fatty acids, methionine, isoleucine, and threonine. The building blocks of protein in the food are broken down to make propionyl-CoA, and then with different steps produce succinyl-CoA, and then that gets to produce ATP inside the mitochondria. That's the powerhouse of the cell to make the energy that we need for all our muscle functions. The different enzymes, the different genes code for the different enzymes in the pathway. PCCA and B are the genes that are important for the propionyl-CoA carboxylase enzyme that is deficient in propionic acidemia patients. There are 3 different genes that code for the methylmalonic-CoA mutase enzyme, or the cobalamin A or cobalamin B enzymes that are important for the reaction of methylmalonic-CoA to succinyl-CoA. And then the MMA CHC enzyme that the gene codes for the cobalamin C deficiency, that is the gene that is important to process the vitamin B12 to the 2 active forms of adenosylcobalamin and methylcobalamin that help the reactions inside the mitochondria and outside in the cell that make that result in high MMA and homocysteine, so and cause the most common form of the combined defects that not only have MMA but also high homocysteine and low methionine. So those are the 3 main groups that we will be discussing today. And our disorders affect many systems in the body, because organs that need high energy production, of course, and need a lot of ATP, have a lot of mitochondria, like the brain, the muscle, the kidney, the heart, the liver. They are all severely affected and can be affected in the children. Kids can have intellectual impairment and basal ganglia stroke or seizures, develop chronic renal failure, have recurrent episodes of pancreatitis. Many kids suffer from GI mobility problems and have a gastrostomy or gastrointestinal tubes. They have bone marrow failure and anemia, low white cell counts, immunodeficiency, weak bones. They can have large livers or fatty livers and are prone to hyperammonemia. They have arrhythmias and cardiomyopathy or optic nerve atrophy. But not all children will have all of those symptoms. And propionic acidemia can affect more of the heart, and MMA affects more the kidneys. But both propionic and methylmalonic children can share many of those manifestations. What they both share is, of course, this recurrent ketoacidosis, severe decompensations that bring them to the hospital with any minor infection or stress, this metabolic instability that causes a lot of admissions and severe stays in the hospital for our children. The different factors that affect how severe the kid will be is the genotype, the mutations. So there are certain mutations that produce no enzymes or very little of the propionic-CoA carboxylase or the methylmalonic-CoA mutase enzyme. They're the most severe mutations. And in our community, we know certain mutations that cause milder phenotypes. The time of the diagnosis, if kids are picked up very early, either prenatally or right at newborn screening, it can be treated very early, can have a better outcome. Of course, many of the very severe MMA and PA children are presented with very severe hyperammonemia before the newborn screening result is even available. And then we have these later presentations. And then we have the B12 response is a very critical part in this severity of the disease. And so if kids can be treated with B12, they can be treated long-term and have milder outcomes. And we used to do this with an in vitro assay on skin fibroblast from a skin biopsy, where we put the fibroblast in a dish and see how fast they can incorporate the propionate. And then we expose the cells to B12 to see if they respond. And that was the way we were calling the mutates patients, MAT0 or MAT-, and clinics would treat the kids with injectable B12 for a week to see if they would respond, and the MMA would decrease in the plasma to say again, is it a milder patient or a more severe patient? And our group tried hard to develop a stable isotope breath test to do this not in a skin biopsy in a dish, but in vivo. And I will tell you a little more about that. So again, the B12 responsive forms are milder. So the cobalamin A MMA, MAT-, and of course the cobalamin C children, they can receive B12 and have a better growth, tolerate more protein, have later onset of the renal disease, better recognition, but still be at risk for acute neurological complications like a stroke or a optic nerve disease. But there's very severe MAT0 and cobalamin B isoforms, subtypes. They have multiple hospitalizations, severe acidosis and hyperammonemia. Many have gastrostomy tubes, poor growth, early onset of the kidney disease, more severe cognitive issues, recurrent pancreatitis episodes, optic nerve disease, and higher morbidity and mortality. And as I said, we try to develop this easy isotope breath test where we give you a very small amount dissolved in water. And there is no blood draws or anything invasive involved. You drink a little drink with labeled propionate that then we can track how fast it is oxidized in the liver to be released in the breath as carbon dioxide that we can measure, and within 2 hours we can tell how much of the methylmalonic mutase or propionic carboxylase activity the kid has. And then we did that in many of our patients over these last several years, and many of you have had that test in our protocol at NIH. And we are able now to show that people with this higher activity, as expected, have higher IQ scores. Here is shaded, around 100 IQ is normal, and people that oxidize a lot of this label in these 2 hours, they have better neurocognitive outcomes. They have later onset of the kidney disease. So here I show that 50% of the people with very low activity will develop severe kidney disease by 8 years of age, as opposed to the ones that have more enzymatic activity that would 50% of them would have kidney disease in their in the 30s. And then we hope that to be able to use this test for our treatment therapies, where we will give the enzyme replacement to the children and check before and after gene therapy or mRNA therapy to see that here we tested people before and after they had a liver or a liver and kidney transplant. And if you replace the whole liver, you improve this enzymatic activity, replacing the whole liver cells with normal enzyme, and it's completely restored to normal levels. When for kids that have only a kidney transplant, there is a lower correction. The severity of the disorder is also different by subtype. So the serum MMA that the clinics are following in the children is extremely can be very high in people with a MAT0, the severe enzymatic defect, much lower in the MAT-, very low in the cobalamin A, and higher in the cobalamin B. And MMA children with kidney disease, when the kidney function is less than 50%, the MMA is always over 1,000. And you cannot treat that with the diet because the MMA is not filtered and cannot be lowered from the kidneys. And we worked hard with our mouse model and we came up with more biomarkers. I'm only mentioning here the fibroblast growth factor 21. That is one that we and people in Europe described as an important biomarker for MMA because it's very elevated in kids with severe liver mitochondrial problems in MMA, and it's very high. Again, it's much higher in the MAT0 and lower in the milder subtypes. And this biomarker completely improves with a liver transplant. So what do we do currently for treatment for our children? We try to reduce the propionic CoA that comes in this pathway because the enzymes are dysfunctional, and we try to reduce the protein that the kids get with very specific dietary prescriptions. We use the special formulas that have less of the valine, isoleucine, methionine, and threonine. We use antibiotics to reduce the propionate that it's made in the microbes in the gut. We have carnitine that is what binds to the high propionyl species and makes propionyl carnitine that people can is more soluble and you can excrete it in the kidney, in the urine. We have carbaglu, which is another very useful tool to treat very severe hyperammonemia. It helps with reagenesis and can lower the ammonia in acute crisis. There are many children have chronic acidosis and need Bicitra that we use to help with the Krebs cycle. And then we use different antioxidant cocktails in kids that we know have severe mitochondrial dysfunction. But of course, the more effective therapies are the B12 if the kids are B12 responsive. B12 is the main therapy. Liver and gene or mRNA therapies are ways to replace that enzyme in the main organ that expresses those enzymes in the liver. So what has changed recently in MMA management? Of course, newborn screening has improved the diagnosis and the detection, especially of the milder forms early on to allow for early initiation of treatment to prevent the complications later on. Carbaglu, as we said, for hyperammonemia. Many kids get gastrostomy tubes that allow overnight feeds and hydration and compliance with the diet and the medications that is significantly improves survival and management at home and in acute crisis. All the antioxidants and anaplerotic agents, there is a lot of research and new research on small molecules that could help with these secondary dysfunctions in MMA. People refer their children earlier for liver transplantation. We have improved dietary guidelines about the medical food use, and there's higher concentrated forms of B12 and they use in younger children are the three main things that I will touch on a bit more. Liver transplantation. We know that it eliminates the metabolic crisis. So kids after the transplant largely have no severe metabolic ketoacidosis. The procedure is done in younger children and has improved in terms of surgical mortality and morbidity. So there is a recent trend to transplant young children before they have the severe acidosis and acute and chronic issues with their MMA. It improves their appetite, the growth, and can slow the progression of the other organ complications. On the other hand, it's a very severe surgery. There is a lot of surgical complications, thrombotic events, rejections that can happen in the organs. The children need to be chronically on immunosuppressants. There are neurotoxicity from the different medications. There are lymphoma or other complications that can happen after transplants. And there is also a limit in the lifespan of the transplant. So there is still need for a better options. They lower, but they don't normalize the metabolites, the transplant, the liver transplant, and it doesn't completely prevent CNS complications. So it is unfortunate, but well recognized that kids can have a metabolic stroke or worsening optic nerve disease even after a liver transplant. This is why we all recommend continuation of the metabolic therapy and the diet even after the procedure. It's not a cure. So I'm showing you here two major papers from a group at Stanford and a group at Pittsburgh who have performed many of the surgeries and just to show that MMA will significantly reduce after a liver transplant, but it's never completely normal. The same with glycine or ammonia levels in PA and MMA. And here, like, I'm trying to show the timeline that what is currently kind of proposed. A liver-only transplant in very young children, as young as infants, is now performed for this very severe MAT0 and Cobalamin patients that have those frequent hospitalizations, the very severe crisis, hyperammonemia, very little protein tolerance, and very slow growth. Once the kids get in this late first decade or in the second decade of life, they start having severe kidney dysfunction. So then the option is to replace the liver and the kidney together in this intermediate severity with renal disease patients. And then for the milder patients that are not as severe to be transplanted earlier, they can have a kidney-only transplant when the kidney disease reaches a stage that they need a kidney replacement. And that's for the milder, later onset kidney disease patients with no severe recurrent ketoacidotic crisis. Our group had been able to see so many patients from different metabolic clinics in the US and as well as international, allowed us to see the spectrum of different dietary managements in our population. So you all know that children with MMA or PA, they have to have the natural protein mixed with a formula, special formula that doesn't have those amino acids that make propionic CoA, valine, isoleucine, methionine, and threonine. And it's always a very difficult balance and constantly changing target to get just the right amount of both natural protein and medical foods. So we try to reach around 1 gram per kilogram per day of the complete protein. And then on top of that, we have these deficient formulas. But in our study, we started seeing kids that had a lot of medical food use. And then this too much protein and too much nitrogen in medical foods cause overfeeding, obesity, fatty liver. They have a lot of nitrogen from all this protein load that puts them at higher risk for hyperammonemia and kidney disease, mitochondrial dysfunction, and lactic acidosis. And then the leucine in the medical foods was causing a very low amino acid levels in the plasma. And many of the children were on valine and isoleucine supplements and had poor growth or microcephaly when this ratio was too high for the medical foods. And then, of course, on the other end, we don't want people not to be on too little protein or no medical foods either, because the right amount is definitely needed for. Otherwise, you have a very low protein intake, short stature, low amino acids, bone marrow suppression, weaker bones and muscle mass, delayed puberty, and the problems of the very low end of protein intake. So there is this very difficult balancing act to get it just right. And the new PA guidelines in 2017 incorporated this evidence and lowered the recommendations of the total amount of protein from 200% to like 120. And we recommend about 2/3 complete protein, 1/3 medical foods. And then, of course, this has to be monitored by your dietitians and your clinic very carefully with amino acid measurements and follow-up. Similarly, with this work showed that use of medical foods and valine isoleucine supplementation was completely contraindicated for cobalamin C deficiency children. And again, in 2017, evidence from our paper helped to completely clearly state that MMA and PA formulas have no methionine and they're not the right formulas for kids with cobalamin C deficiency. That brings us to the cobalamin C. Again, a multi-organ presentation. The kids can have many organs affected, primarily the nervous system and the eyes. The maculopathy and vision issues are the primary concern in these children. And what is important here is that many of those manifestations start very early, in the first few months of life, even in utero. Kids can be born with very small, with smaller heads, with congenital heart defects or coloboma. So this is a disease that we need to treat as early as possible. Treatment is daily, vitamin B12 shots, betaine, carnitine, and folinic acid. Again, being able to see children over more than a decade through multiple different centers allowed us really here to show that newborn screening has significantly improved the outcomes in cobalamin C deficiency. Kids that we had earlier in our study that had symptomatic presentations compared to kids that were picked up at newborn screening and treated better early on. They have better cognition, they have better head growth, and they have much less risk for epilepsy and seizures. And then we, our group and others have observed that treating the children with 1 milligram every day from when they're babies all through their life was not enough. So 1 milligram a day is 0.3 milligram per kilogram per day. And some of our older individuals that were on that same dose had homocysteines that were 150 over 100. So we started increasing the dose to keep that 0.3 milligram per kilogram per day throughout the lifespan. That would be 10 milligram when you're 1 year old, 20 milligram or 30 milligram when you're older. And we saw a very nice reduction in the metabolites with higher B12 doses. But the question was, what is there a clinical benefit to keeping the metabolites so much lower? And yes, again, we are able to show that higher B12 dose resulted in better neurocognitive outcomes, as well as more natural protein. So no protein restriction, no medical foods, more B12 is better for the cognitive outcomes, but we cannot convincingly yet know if it makes any difference for the eye disease. So I have here a very nice illustration of this maculopathy. This is the back of the eye, the retina. This is the optic nerve, and this is the macula, which is impossible for is important for the central vision. And the macula over time, 4 months, 7 months, 20 years, shows a very significant destruction here and a thinning. So the normal thickness here of the macula gets very thin in kids with cobalamin C already at 4 months or 7 months. And there's a study that was recently published with, which went all the way to use these very high doses of 20 and 30 milligrams a day in newborns and very young infants, and showed that those children had, although they had this very severe genotype of cobalamin C, they had a better neurocognitive outcomes at 3.5 years and better vision, which was very encouraging. And we were able to see one kid in our study that had 5 milligram a day cobalamin since the first month of life. And indeed, his optical thickness was normal. So that's very, very, of course, encouraging. And we need to certainly study this in young children more to determine that it is safe and effective and make it available for more families. So participation in the research is very important. We have seen many patients, of course, over this decade, and we were able to develop better guidelines for therapy, discover new biomarkers, and improve long-term outcomes for the children. Your support of our research group has helped enabling 3 new therapies that are soon entering phase 1 and 2 clinical trials, and Dr. Venditti will talk a lot more about that. I know the Organic Acidemia Association has a registry, which is very important to document the incidence of the disease, the burden in the families, and what unmet needs we have. And we are here as partners, and we will work with the patient advocacy groups and with all of you to educate you and try to help bring those new therapies to the clinic. With that, again, of course, stay safe until we get to the new therapies. We have to all make it through 2020 and COVID-19. Please wear a mask, wash your hands, watch your distance. And the vaccine is around the corner, and the scientific community and NIH has made an incredible, amazing effort with international community and the scientists to bring this vaccine to us. And hopefully we'll get back to our normal lives in the next several months. So with that, I thank all the families. We would never do any of this without you. And we are here, despite COVID, we are available for telehealth appointments, and we have stayed in touch with as much as we can with the families in our study. And with that, I'll stop sharing.
I think there's a couple of questions out there. If Jen wants to share what they are, and you could answer live, or just a couple. Do you want to go ahead?
Yeah, there's a couple of questions. Hi, everybody. It's nice to see all of you, many of familiar names, and thanks for joining the session. I'm just going to ask a few questions, Dr. Manoli, that came up in your chat in the Q&A during your session. And the first one was about cobalamin C and whether or not children with cobalamin C can have high ammonia levels.
So it can happen rarely in the very first presentation when the babies are presenting and are not treated yet. So it can happen. It's very rare. But if you have the very severe early onset cobalamin C deficiency and are not diagnosed for the first few weeks or a month or so, you can have a very significant presentation with hyperammonemia, but it's very rare. On therapy with B12 and betaine, once the kids are treated, despite they can have infections, they have other severe other issues, but they don't get this hyperammonemia and metabolic acidosis like our MMA, MAT0 or Cobalamin B or other forms of MMA. But it's not, it can happen, but it's on therapy, it's very rare.
And the second question is regarding liver transplant, just in general, what's the expected sort of lifetime for a liver? Like how long will a liver last if it's transplanted? And then I think they're also asking about, a complication called PTLD. So can you just
you kind of said, and I shouldn't put the initials there, this is a lymphoma that can happen. It's a post-transplant lymphoproliferative disorder. And it can happen. It's a rare complications with liver transplant, but it has occurred. We have 4 or 5 patients with MMA MAT0 that have developed this. It's a treatable complication. It needs chemotherapy, and but it is one of the known complications of transplantation. The lifespan of transplants is improving with the better immunosuppressions that we have now. We have people in our study that had their liver and the kidney for up to 18 years or so after the surgery. So it's, but if it's still, there is a limited full duration of the transplanted organ. So for the infants, we will have to see. There is a lot of very young patients now that have been transplanted as babies, and we will have to see in the setting of MMA how long those transplants will last. But there is a lifespan for the transplanted organs. There is not a permanent solution for 80 years, let's say. This is why we believe those new therapies, but I thought the Q&A is better to keep for the very end, right?
Yeah, we'll finish the rest. There was a couple that were more specific
to
your talk. So
go ahead, Jen.
I'm gonna just run a poll real quick for everyone that's on the call right now. This is just gonna kind of give us an idea who is on the call today. If you can share, is everybody saying whether you have MMA or PA? We just kind of get an idea of how many are on the call today. And we'll have different polling questions throughout the talks to get your input, and then we'll start. The next presentation will be Dr. Oleg.
I will go ahead and answer some questions, on the chat. Go ahead. I stopped sharing, right? No?
Yeah, you did.
Okay.
All right, I think everybody's kind of out in the polling. Share the results. We have
good. We have
probably more MMAs, which is not unusual, than PAs on the call.
And we have Cobalamin C because I wasn't sure how many.
Yeah, and then there's the Cobalamin Cs are on the call. They all wanted to hear Dr. Irene's talk. Okay. Then we're gonna
I'll go ahead and share my my screen.
Okay.
Okay, hold on a second.
And I apologize, I'm not going to try to chop up Dr. Oleg's last name. So I always call it
There's a good reason why my first name's Doctor.
Yes.
So yeah, Dr. Oleg is perfectly fine.
Okay.
Can you see my?
Yeah, you're not in presentation mode, but that's fine.
All right, hold on.
I'll introduce you though. Dr. Oleg is an associate physician investigator in the intramural organic acidemia research section of the NIH. He's board certified in pediatrics, clinical genetics, and medical biochemical genetics. Using clinical research, data science, and molecular biology, Dr. Oleg is leading efforts to gain new insights into the mechanisms of propionic acidemia and to create a path for novel genomic therapies. And with that, we'll let Dr. Oleg start.
All right. So I want to confirm that everybody is able to see my slides.
We can see even your second slide too. So I don't know if you want to change the display setting.
Interesting.
Yeah, you can do that, and yeah, click there. And then I think duplicate slideshow. Try that.
Yeah, so are we in the right mode now?
You know, we can still see your second slide, but that's, yeah, we can still see your second slide.
I have an idea. So I'm gonna stop sharing. I apologize for that glitch. I'm gonna exit my presentation mode, and I'm gonna share my first screen. How about now?
Yeah, it's still, yeah, now you're in presentation.
Okay, so we figured it out. Okay, I apologize for this minor glitch. I'm glad it's working now. Hello, everyone. I wanted to thank you for joining our session today. It's a great privilege for me to be part of this panel and to meet all of you virtually. I'm looking forward to talking to you about the research that we do at NIH. So you will hear a lot of things that Dr. Manoli mentioned, but I'm going to sort of tell many of the same things, but I will try to weave them the story around a natural history study, so that you can, as you listen to this talk, I would like you to think about, okay, so if I were a patient to join the NIH natural history study, what it would look like to me, and what would happen to all the numbers and samples that we collect during this visit, and how does that contribute to other patients' health and research and discovery of novel drugs. So these are the kind of questions I would like you to think about as you're listening to this talk. I have nothing to disclose, and we're going to talk about, again, just this quick outline. It's the mission of the Organic Acid Research Section at NIH that is headed by Dr. Venditti. I'm going to give you a brief overview of PA and isolated MMA. We're going to talk a little bit about how natural history is organized and how it's done, and what we do with the information that we collect and learn from the natural history study. Dr. Manoli mentioned it's a large group. There are lots of people involved. What I want to highlight is that clinical research is a teamwork. And the picture of our team here is it's a group of people that is dedicated to thinking about your disease. We spend most of our time thinking about your disease. We talk about this. We exchange emails. We field many emails throughout every week. We are on phone calls with other doctors and families trying to figure out how to optimize care if there are any issues. But I just wanted to say that you have a group of people who are at NIH who are dedicated to studying your disease, and this is what we do most of our active time. And the NIH Clinical Center is located in Bethesda. So many of you have been here, and we wanted to thank you for your participation. It's a wonderful hospital. It's like any other hospital in the world, which has a lot of things to offer, but it has one thing which is very unique. It doesn't have an emergency room. What does that mean? It means that every patient who comes to NIH needs to be enrolled on a natural history study. It means there has to be a protocol, an agreement with the clinical center that allows us to bring patients to the NIH Clinical Center. We're very fortunate to have the MMA and PA protocol, which was started many, many years ago by Dr. Venditti, and that's what allows us to bring patients to the NIH campus. Now, I wanted to highlight two things. So the clinical center is a teaching hospital. So people, if you've been here, you may have seen medical students, residents, fellows, visiting scholars who see patients with us. And there are two really things happening in the rooms when we meet you in the clinic or on the inpatient service. Two things. First, you educate us. It may sound a little surprising, but the reality of rare disease research is such that there are many questions that we don't know answers to, and there is no textbook that we can turn to and say like, oh, I can just look it up and find out the right answer. These diseases are sometimes so rare that our patients are really becoming our textbooks. So we want to read these textbooks carefully. You may have heard me use this illustration, but it is true. Your life and your medical history and the the clinical notes that you give to us, these are our textbooks, and you educate us. So there's something I don't know, I will be the first one to acknowledge that I don't know. But the second thing that happens is that you train the next generation of doctors and scientists. Every single encounter, when you meet a younger trainee, you get an ambassador, a person who knows about your disease, and when they go out and they pursue their medical and scientific careers, they will be thinking about you and the impact you made on their lives. So I wanted to thank you for that contribution. But obviously, ultimately, all credit goes back to our families. We wanted to thank you for your time that you take out of your schedules to travel to NIH, to participate, to go through many days of this constant studies and conversations that you have with us and other teams who are involved in your care while you are at NIH. So we wanted to thank you. So I wanted to provide a brief overview. I'm not going to say I'm not going to repeat what Dr. Manoli said, but I wanted you to think a little bit about the biochemistry. Let's think about this together. I think one of the better ways to think about this, or one of the most helpful ways to think about metabolic maps or biochemistry, is to think about it as a map. So here I'm showing you a map of DC Metro. And let's just, so I'm going to change my pointer to a laser pointer. So let's say you are arriving to DC, and you're right here. This is Ronald Reagan, Washington National Airport. You're right here, and you need to get to NIH, which is right here, Medical Center. So let's say there's a train that broke down. And so there are many ways you can get here. And that's how it works with biochemical map. There are some redundancies that we have in our body. And there's a chemical that has to travel from point A to point B. It may have the ability to go around a block and get to its destination, although it may take extra time. But there's some other strategies of the biochemical map that, just like here, there's only one way to get from point A to point B over here. And if the train doesn't work here, then, passengers have to find a different way to get to the medical center. And that's exactly how it works with the biochemical map. There are chemicals that we know are present in the diet: valine, isoleucine, methionine, threonine. These are the 4 amino acids that we try to reduce the intake of using medical foods. They have to get from this destination, from the diet, to this destination. And as they travel through these different biochemical pathways, they become a source of energy. And that's essentially what this pathway is all about. If there are these chemicals encounter a block, like for example, this is a block for propionic acidemia. This is a block for the classic form of the most common form of isolated methylmalonic acidemia due to the loss of function of this enzyme. So then these chemicals have to find different ways to get to their destination. Sometimes they cannot do that. So they have to get off their trains and go somewhere else. So you see elevations of some of these chemicals. We call them biomarkers. They can be used for newborn screening. They can be used to diagnose and confirm the diagnosis. Of course, there's a big question: they be used as biomarkers? So you will hear this question, this term, a little bit later in my presentation. So does this pathway matter? There are many different chemical reactions, trillions of chemical reactions that happen every second in our body. But do they matter? For this particular pathway, we know it matters a lot. So it's not Dr. Manoli mentioned that, if this pathway doesn't work well, then it can lead to many consequences in our bodies. It can cause problems with the eyes, heart, liver. It can make your bones weak or suppress the bone marrow, cause GI problems, kidney problems, brain issues. And of course, it can cause metabolic instability. And that's one of the most feared complications of MMA, PA, some other forms of organic acidemias, which can lead to hospitalization, elevations of ammonia. So when we look at at this disease and a patient comes to NIH, what happens at the NIH? So I want to take a step back before I even dive into this question. What I think is important is that if you would consider participating in the natural history study, we strongly encourage you to participate in all other natural history studies that might be out there. For example, there are registries. and we want you to participate in registries because all this information is going to be very helpful. So it is important for us to provide this information to as many investigators and scientists and clinicians as possible. So together we'll keep thinking with you about your disease and find new ways to treat this. But what is a natural history study and how is it different from let's say, registries? So first of all, natural history study requires teamwork. So in the middle, that's the family. It's the patient, it's the family who travels here, it's the physician. But it requires a teamwork of NIH doctors, nurses, and research team here, and your local team. In other words, when you come, we'll generate some recommendations. We'll think about your disease. We'll need to communicate it back to somebody. So we'll communicate it back to you, but it is important for us to have your local team involved. So that's why you will see us, often if you, for example, send an email to us and ask us a question, we will try to loop your team into this conversation so that we all remain on the same page. So before we had a situation with COVID, you were able to travel to NIH. So currently, it's much harder to do, but I'm optimistic. And I hope that in the next several months, we will be able to solve this problem one way or the other, and we will be able to bring patients to NIH at the same sort of massive volume that we had before COVID. But even if we enroll you using telehealth visits, for example, virtually by phone or using a computer, certain steps are exactly the same. We need to collect your information using your outset records. So that's why you see, for example, Susan Ferry, our research nurse, will be asking for records, and because that helps us to understand your disease much better. Then we collect clinical information, we do labs, and we also do biobanking, meaning that we collect blood, urine, microbiome, stool, exome information. It's all stored in our freezers or on our computers, and we use that information to follow up on some of the findings. So far, and I'm using this. This is an update on the Propionic Acidemia cohort. We've enrolled 40 patients. Most patients are not transplanted. We have 5 patients who underwent a liver transplant, and we are very grateful to everyone who participates. But we learned so much also, in addition to things to learn about PA. We also learn a lot from patients who underwent liver transplant, because that creates an opportunity for us to ask a question. If a patient were to receive a new therapy, for example, mRNA therapy or gene therapy or small molecule, what type of changes should we anticipate, and how can we use that information to design a clinical trial better? We have about 50-50 male and female, about 50-50 or equal distribution of patients who are affected by BCCA versus BCCB. As you remember, there are 2 enzymes. Actually, it's 1 enzyme, but there are 2 subunits. They have types of subunits that have to come together in order for this entire enzyme to work well. And finally, that was one of the interesting findings in this study, is that we have so many patients who are older than 18 years of age, young adults and adults. That's very encouraging. That means our patients survive, they receive good care locally. And that also means that there are newer problems we have to start thinking about, such as kidney function, hypertension, elevation of lipids in the blood, which is something we don't necessarily see in the younger population, but we do see them in adults affected with PA and MMA. So I wanted to highlight the power of bringing many observations together, and this is what I just wanted to orient you. This is one of the findings that we made during the study of natural history study of propionic acidemia. I'll just orient you to this chart. So what you see here on the x-axis is the age of visit. So whenever a patient comes, we'll take a look at your age, and we make a mental note about it. We also do a test that allows us to get a better sense for how well the kidney function is working in your body. For PAs, we don't necessarily do direct measurements, but we can use this chemical called creatinine in the blood to get some sense about how well the kidneys are working. Most patients, under normal conditions, healthy individuals, their numbers will fall somewhere between 90 and 120. So most people will be in this range. Once there's diseases of kidneys or natural senescence process may result in a decline of the kidney function, and then you see this number start going down. So depending on how far down goes, you get different assignments of the kidney dysfunction by group. So let's just think about this. What happens to this chart when we bring a patient? Or what happens when we bring several patients? And this is just as an illustration. So this is the same chart. And if you really squint your eyes, you can see there's there's a dot here. This is one patient. This is the second patient. This is the third patient, and so on. I just put like 20 slides here, 20 charts here. And if you were to ask yourself the question, well, what is really happening to the renal function over time? Is there a trend? Is there something that we can see that we couldn't see before? So if you just look at this, at the kidney function, this chart individually, it's really hard to make sense of this. So if you have 2 patients or 3 patients in, like the doctor has 3 or 4 patients in their practice, it's still really hard to see the big picture. What happens if we were to put all of those things together? And what we see is there's a picture emerging. We begin to see trends. And that's when we come together, united we stand, but divided we'll fall. So this is a good illustration, is that when we bring all these numbers together and we bring as many patients as possible, we begin to see trends. And what's very clear from this, the big trend is that with age, there's the onset, the kidney function can decline. All right, well, let's just think a little more carefully about this graph. So this graph then allows us to start asking questions which will help us define our research studies in the years to come. For example, why is this important? Is this an important observation? I believe it is an important observation. First of all, for example, when should we start screening for kidney disease? If you look at this chart, it looks like, well, it would be nice to get a baseline and maybe a couple of them the first 10 years of life, but it's important to start screening for this condition in the second decade of life, start paying more careful attention. So that's one important lesson that we learned. And the second observation that you can make here is, if you really kind of look carefully at the patients who are in their third decade of life, they're clearly two and older. There are 2 subsets. There are some patients who are here with the lower kidney function, and there are patients who are doing just fine. Why is that? Is there something that happened in the past in these patients that determined different trajectories? Or is it different types of treatments? Or is it different type of mutation? So when we start asking follow-up on these kind of questions, it's a little bit of a detective work. It's kind of a lot of fun to think about those issues. But it is also, when we start asking those questions, we are looking for ways to change the trajectory to prevent these type of outcomes from happening. It also, prompts us to think about, well, if the kidney function goes down, what happens to the biomarkers? Remember, we talked about biomarkers earlier. What does that mean for patients' eligibility in the future clinical trials? What does it mean for the design of new drugs? So we start thinking about maybe we need to find new medications which will be targeting kidney to improve the health of the renal health. What about transplant decisions? I'm sure people are asking, well, what does that mean? When should I get a kidney transplant? Is it okay if I wait for as long as possible, or should I do this preemptively? These are important questions that I think can be only answered, after reviewing every patient's specific situation. Or another important thing, if renal function is this low, what does that mean for other medications? The antibiotics that I take, anti-serum medications, do I need to adjust the doses? So again, you see, we start with one single observation, we pull them together, we see the big picture, and that then helps us to ask another set of very important questions, and that helps us get closer to a better care for our patients and hopefully important information for the clinical trials. All right. So you've heard us use the word biomarker. So what is a biomarker? Biomarkers essentially, it refers to, more often than not, to chemicals that float around in our blood, or present in our urine, or present in our breath, and this is what we study. We try to answer the question, which of these chemicals can be used to understand whether how well your body will respond to new therapies. So this is a very important question because FDA, let's say we have a novel drug, we go to FDA will ask us the question, well, how do you know it's working? So you need to demonstrate some kind of chemical that improves, and that chemical is relevant to this disease. So if you were here at NIH, and went through a blood draw, sometimes you will see that's a big lineup of tubes that we collect. So some of those tubes are used immediately to collect clinical information. We provide you with the results, and your doctors also get the results. But some of these tubes are stored in our freezers, and we use these blood samples to follow up on some of the previous observations, and we try to understand which of the chemicals, the new chemicals, old chemicals that have been known for a long time, can be used as biomarkers in clinical research, clinical trials under supervision of the FDA. So Dr. Manoli already mentioned one of the studies that we can conduct here at NIH is a breath study, it's the oxidation study. And so one of the reasons why we decided to pursue this particular study was because we noticed that some of the biomarkers that we thought we can rely on may not perform very well in the situation of reduced kidney function. So we're trying to find a different a method that would allow us to, find a new biomarker, which would be a little more resilient to, for kidney function, for example. And this particular test appears to be a reasonably good candidate. So we need to answer many more questions, but this is one of the ways that we can use the information from the natural history study to position us better for a successful clinical outcome, and help companies which are pursuing new therapies in MMA, PA to find biomarkers that will help them get to the right answer. So I'll just share with you that you may have seen this particular chart from other presentations, but I'll just orient you to this. So the CO2, how much CO2, labeled CO2 recovered in breath in patients who undergo this study can correlate with the severity of the disease. So when we measure it, for example, in healthy controls, and we'll look at the amount of labeled CO2 in their breath, we see most patients have the average numbers close to 50%. Patients who are affected by propionic acidemia may have a very low recovery rate for the labeled CO2. And then patients who undergo liver transplant, when we test it, we see the restoration of the recovery of CO2 in their breath. So that tells us this test can, for example, can be used as a readout for a clinical trial, and trial that targets the restoration of liver enzyme, propionic acid, propionic enzyme A carboxylase activity in the liver. So again, this is yet another illustration how an observation of the renal function prompts us to think about biomarkers, prompts us to think about what other ways that we can measure liver enzyme activity, and so that information then can be used to design a more powerful clinical trial. So, and with that, I'm going to stop here. And if there are any questions, probably short questions that I can address, I'm very happy to do that. But if there are other questions that you feel, Jan, that are a little more loaded, we can wait until Q&A.
Yeah, I think there was a couple, but I think we'll wait till Q&A because they're sort of bigger questions.
Bigger questions. Okay, yeah. Thank you.
Okay.
I think I'll throw out another poll question here for everyone about participating in the study to see how many have actually participated. Obviously, living outside the United States might inhibit some from traveling, but I think you have seen patients from outside the US in the study before, I believe.
Of course, many.
Give it a few more minutes. Okay. In that polling, I'll share the results. We got like half and half. So it looks like almost for that. see if I have another. I think I'll just do one more poll before we go to the next speaker about treatments.
There's many questions about how to participate in the study. Maybe at the end with the Q&A we can answer that. Yeah.
Yes, we will. We can.
And Jen has put our email there for contact. We see patients from all the countries. Our problem is we don't pay for the trip to NIH, but everything during the NIH visit is covered from our research funding. But there's no, yes, Ireland or India or whoever, the problem is getting to the US, and of course the metabolic, the health concerns. So we have to discuss if the trip is safe with every participant and all of those things. But it's a longer discussion, and we can address by email or discuss a little bit at the very end with the Q&A.
Well, it looks like people are somewhat satisfied with the treatment, so that's good, because there are hopefully going to be some new treatments coming soon next year, clinical trials. So we're going to go on to our next speaker, which is a new person on the team there at the NIH, Dr. Chris Jordan.
Hi.
He's a pediatric and fetal cardiologist, currently working in Dr. Venditti's lab as part of a clinical fellowship in the medical genetics and genomics at the NIH. He attended Dartmouth Medical School on a health professions scholarship from the U.S. Army. After completing training in pediatric at Tripler Army Medical Center, where he served as chief resident in pediatrics, Christopher completed a fellowship in pediatric cardiology at Children's National Medical Center in Washington, D.C., where his research focused on and I never can say that word right, philosophy and arrhythmia device management in children affected in heart rhythm problems. He served as chief pediatric and fetal cardiologist for 6 years at Walter Reed National Military Medical Center in Bethesda, Maryland, and Womack Army Community Hospital in Fort Bragg, North Carolina, caring for families affected by congenital heart disease and related conditions. And he's interested in helping work towards a better understanding of the underlying genetic causes in heart disease in children and their families, and lead them to pursue further training in genetics and genomics at the NIH. Chris' current areas of research is in the Dr. Venditti's team includes Dr. Oleg in reviewing the cardiac data from patients enrolled at the NIH Propionic Acidemia natural history study, as well as investigations on cardiac imaging and the adenovirus associated virus gene therapy in mouse models for PA. And with that, he's got some interesting information on hearts.
Thank you, Kathy. Can you all see my slides and hear me clearly? Great. So thank you so much for that introduction, and thanks everyone for the opportunity to get to meet each other. It's so exciting to be a part of this great team. In the next few minutes, let's see if my slides can advance. I have no financial disclosures. We'll spend about 12 minutes reviewing select cardiology issues in the organic acid disorders. We're going to consider some of the long-term cardiology evaluation and management strategies, and we'll take a few moments to explore some of the future aims and current work happening right now this fall, despite COVID, related to the cardiac diseases that can occur in patients with organic acid disorders. So cardiomyopathy is the most commonly written about and discussed issue, but there are some other cardiac disease issues to think about in this patient population. So in addition to dilated cardiomyopathy, we also see now, in particular in the cobalamin C deficiency patient population, an apparent increased rate of a different form of cardiomyopathy known as non-compaction cardiomyopathy. So we'll take a little bit of time to talk about that today to make people more familiar with that term. We'll also talk a little bit about EKGs and QT prolongation and arrhythmias and what that means. And then I also want to emphasize that other issues that your cardiologist may not necessarily bring up at a cardiology visit with you, but that can affect your child or your own heart health. So the overall kidney and liver health and your transplant status, the presence or absence of hypertension, polypharmacy or being on many medications can affect the heart health. And then neurodevelopmental issues and behavioral health and psychiatric health factors and some of the medications used to treat those conditions can also affect the heart rhythm and heart health. So to say it another way, there are many, many factors that influence heart health in families affected by organic acid disorders. And we've already heard thoughtful comments from Dr. Manoli and Dr. Oleg about the medical diet, about your genetic background, liver and kidney health, the medications you're on. You know, in the time of COVID, we certainly think about infections, and we're learning about how COVID can affect the heart and as well as other illnesses. And your activity level and conditioning. You know, just because we're focused on organic acid disorders doesn't mean we shouldn't also be thinking about good preventive cardiology health and making good lifestyle choices about remaining active, which can be really hard right now, especially. I wanted to bring up a few cardiology terms that you might hear, and I promise we won't get too steeped in jargon, but cardiologists, we think about the heart as a pump, and we talk about the heart function. When a cardiologist talks about your heart function, they're talking about how well does the heart squeeze and relax to fill with blood. When they talk about contractility, they're thinking about, well, how well does the muscle squeeze? If you could look at the heart's muscle cells at the cellular level, how well do they contract or squeeze to pump that blood out to deliver that good stuff to the rest of the body? And then preload is, you know, an idea that we use to think about the blood volume that's going into the pump. The afterload, we think about the shorthand way of thinking about it is your blood pressure or the resistance that the pump has to work against. Cardiologists use these concepts to think about how we're going to treat a heart problem in a patient. So common cardiac medications that many patients with cardiomyopathy and rhythm issues will find themselves taking include the beta blockers. Those are things like atenolol, metoprolol, carvedilol, nadolol. The ACE inhibitors or angiotensin receptor blockers that work at the level of the kidney to modify blood pressure. They tend to reduce the afterload or make it a little bit easier for the heart to work. And then there's also medicines like furosemide, or also known as Lasix, and other diuretic therapies, such as the chlorothiazide medicines that reduce the preload and can modify the heart function. These are tools in our toolbox. We could spend hours talking about the pharmacology of heart medicines, but I just wanted to give a quick overview of some of the medications that we may find that your family members with organic acid disorders complicated by cardiac issues may find themselves taking. But a healthy heart, when you go to the cardiologist, we get these beautiful pictures. You know, you can see an echocardiogram of a normally functioning heart. This left ventricle is squeezing nicely and it's not enlarged. When you get an echocardiogram with your cardiologist, we're looking at the anatomy, we're looking at how well the valves can open and close, we're looking at the chamber sizes and how well the heart's squeezing. We can also see over time with periodic follow-up if a chamber is enlarging. And I don't know if you can appreciate, but compared to the previous slide, what I'm showing you here is another propionic acidemia patient whose left ventricle is actually quite enlarged. and doesn't squeeze as well as the healthy left ventricle in the previous slide. Dilated cardiomyopathy is not just something that affects people with propionic acidemia. It's a general term to describe a heart that where the ventricles or the pumping chambers of the heart are enlarged or dilated. You can think about more space here, more black between this wall, and decreased function. So the amount of squeeze that you see every time this heart beats, it's not squeezing as much as it should. If we looked across a whole population of humans, we would find somewhere on the order of 1 out of every couple of hundred to 1 out of every couple of thousand people walking down the street have some degree of cardiomyopathy. Reviewing the cohort from the Propionic Acidemia Natural History Study at NIH, we find that in the adult-aged patients with PA, it's around half of the patients by the time they're in their second and third decades of life that they're beginning to show some evidence of dilation. But there is a vast spectrum of severities, and one of the puzzles that we need to sort out and get a better understanding of is why some propionic acidemia patients and why some organic acid disorder patients develop cardiomyopathy while many do not. So this just summarizes for you the definition of dilated cardiomyopathy. And like I said, there's a vast, vast spectrum. So we can see patients who are completely asymptomatic. In your periodic cardiology follow-up visits, where an electrocardiogram or an EKG is done to look at the electrical activity of your heart, or the echocardiogram, the ultrasound, to look at the structure of the heart and how well the heart's beating, that can show, these tests can show subtle changes and signs before you ever feel, or your loved one ever feels, any symptoms. With timely follow-up and checking in regularly with a cardiologist familiar with cardiomyopathy, we can find subtle changes in these tests before a person begins to feel shortness of breath with exercise, or when they go up a flight of stairs, or they can't quite make it around the block as quickly as they could a year ago. What can happen, unfortunately, in some patients, and sometimes despite our best efforts, are worsening symptoms and the increasing need to go on medications or multiple medications to help reduce symptoms and to help you feel better. And at the most extreme end, of course, it's tragic, but there are instances of sudden death related to these arrhythmias, and trying to prevent any of those events from occurring is a big part of what we're trying to do with early and timely follow-up and use of appropriate medications. So I wanted to show you, I showed you a couple of echocardiograms so you could see the ultrasound of what a cardiologist can see when you come to the cardiology visit, which if you came to NIH would be part of the Propionic Acidemia Natural History Study, to have a cardiology consultation, which would include not only an echocardiogram, but this test here, which is an electrocardiogram, which is like looking at the electrical activity of the heart pump. The heart, it's a mechanical pump that is powered electrically from signals from the nervous system. And we can detect and measure intervals. Every single spike you see is a single heartbeat. And in particular, in the organic acid disorders and PA specifically, we see increased rates of something we call QT prolongation. Well, what is the QT interval? The QT interval is the total amount of time in milliseconds that it takes for the heart to be excited and squeeze, and then relax and refill with blood and be ready to beat and squeeze again. In people with normal, healthy conduction systems supplying the heart, the QT interval tends to be around 360 to 440 milliseconds. and people where the QT interval is prolonged. We tend to think of it, if it's longer than 440 milliseconds to 480 milliseconds is sort of borderline prolongation, and more than 480 is quite prolonged. This one is sort of in the borderline range if anybody's trying to measure in milliseconds. We'll have time for questions in the town hall too if people have more questions. This is meant to be a quick overview, so we can all get to hear what Dr. Venditti has to say to us. But I wanted to include this slide about the cobalamin deficiencies, in particular cobalamin C deficiency, and people are beginning to recognize signs in this patient population of something we call non-compaction cardiomyopathy, which is a form of congenital malformation in the part of the heart we refer to as trabeculations. But you can think of these as hills and valleys in the lining of the heart. This is the left ventricle that pumps blood out to the body and the brain through this great big red pipe, the aorta. And the left ventricle tends to be, in a normal healthy heart, smooth-walled and very tough and strong. But in patients with non-compaction cardiomyopathy, the trabeculations are more coarse with deep hills and valleys, and it almost looks spongy when you look at a picture of it from an MRI or an echocardiogram with the ultrasound machine. And people affected by this can be totally symptom-free, or they can get clots that form in these little crypts. And they can also have arrhythmias because the electrical activity that's going through this heart muscle tissue may be abnormal at increased rates in association with this shape of the left ventricle. And unfortunately, even some of these patients require heart rhythm devices such as defibrillators because of serious life-threatening arrhythmias. That is unusual. That is the small minority of patients. And again, like I said with dilated cardiomyopathy, there's a vast range of severities with non-compaction cardiomyopathy. I promise you, there are many, many people walking down the street today all over the world who have a non-compacted left ventricle and don't even know it. So in the last couple of minutes, I wanted to talk about research that's happening right now. At NIH, we have something called the Mouse Imaging Facility, where we have students and scientists and cardiologists and geneticists working together and with veterinarians and veterinary techs. The animals are very much partners in this research. We could not come up with new treatments without our animal models to work with. And we have many organic acid disorder mouse models that we use. And this is a setup where we can actually perform an echocardiogram in a mouse. So we have 2 mice that were fed a high protein diet that would be in excess of what we would ever want our children with propionic acidemia to take, but we give these mice that have abnormal genetics where they basically have a type of propionic acidemia. We give them intentionally high protein, and we see differences in the ability of the heart to squeeze. This gives us a model that we can work with to test and evaluate different treatments and to follow whether potential therapies work or don't work, and how the heart health can be affected by the various strategies we use to treat these very challenging disorders. So the recommendations, periodic follow-up is very important because we are not very good yet at predicting which organic acid disorder patients will develop cardiomyopathy. And so periodic follow-up, and I would suggest annually, although this may vary depending on where you're located and what the local resources are, with a cardiologist who's aware of the association between organic acid disorders and heart disease is important. Cardiology follow-up may include a lot of different things, but I would like to suggest to you that things that you should be looking for from your cardiologist or your child's cardiologist should include an interview, a physical exam with the cardiologist, an echocardiogram, and electrocardiograms. You need to see how well the pump is working mechanically, and you need to see the electrical activity to check that QT interval. Periodic Holter monitors and ambulatory electrocardiograms. Many of you on the call probably have seen these tests, but in case anyone's not familiar with those, that's like a 24-hour or a 48-hour, or even in some cases, a 2-week-long EKG, where you are wearing stickers or a sticker stuck to your chest underneath your clothes, and it's constantly recording your heart rhythm. And we can detect abnormal heartbeats that may not be occurring, you know, in the 6 seconds of time that a normal EKG is recording, but people have intermittent abnormal heartbeats that might occur once every few days. And so these tests are also a good idea to have intermittently, as well as the standard EKG that you would have in the cardiologist's office. Depending on the situation, and if a person has cardiomyopathy, additional tests may include some additional blood work that we do sometimes in cardiology, and other tests like cardiac MRI that we sometimes use in addition to echocardiograms and electrocardiograms. So just to wrap up, organic acid disorders are associated with cardiomyopathy and heart rhythm problems that can begin at any age, but we see them happening in early childhood, usually adolescence and early adulthood though. Molecular mechanisms of how organic acid disorders cause cardiomyopathy remains an active area of investigation. We want to know why or how the toxic metabolites in propionic acidemia that accumulate, because like Oleg said, with the interruption in the flow on the train tracks, you know, how does that lead some patients to develop a dilated heart that doesn't squeeze as well, or arrhythmia, while other patients who may have had even more metabolic crises and hospitalizations somehow do not develop that cardiomyopathy? That is a puzzle that we continue to work on and try to figure out and better understand. And the way we get to better understanding is through your participation in research and clinical trials, and collaborating with the Organic Acid Association and this broader community. It's going to help us move closer towards improved evaluation and treatment options. So thank you so much for your interest and for the opportunity to speak with you.
Thanks, Chris. Appreciate it. That was great. And he told me that was my daughter's heart in those pictures. So just so you know, I gave permission.
Thanks, Kathy.
We're going to go on to we saved the best for last, Dr. Venditti. And I was trying to remember, Chuck, how long ago we met. And I want to say it was 20 years ago when we first met at a conference that OAA was doing in Houston, Texas in 2000, I think. So 20 years ago, right?
That's correct, 20 years ago.
Okay, all right, I'm good. My memory is still with me. That's great. So anyway, I think a lot of our families are anxious to hear your talk. So we'll have a few polling questions after his talk, and then we'll do the Q&As. But I'm going to introduce you, even though most people know you on the call. But Dr. Venditti is the senior investigator at the National Human Genome Research Institute, the NIH, and the director of the Organic Acid Research Section in Bethesda. As a metabolic pediatrician, he has developed a translational research program to study the natural history and clinical phenotypes of the hereditary methylmalonic acidemias, MMA, Cobalamin metabolic disorders, and propionic acidemia. His laboratory is developing gene, cell, and small molecule therapeutics to treat MMA and PA. Dr. Venditti has received a number of national and international awards, including the Presidential Early Career Award for Scientists and Engineers, the U.S. government's highest honor for early career scientist. He has authored and co-authored more than 120 peer-reviewed research articles, reviews, and textbook chapters, and is named the inventor on 17 US patents, which I didn't realize that. But we are just totally blessed to have you studying our disorders. That's all I can say. And we are so happy that the parents pulled you in back 20 years ago to study our disorders. So with that, I'm going to let Chuck start his talk.
Let me share my screen. Well, actually, before I do that, I'll say a few words, which is, first of all, we all at NIH, we miss our patients. And we are very excited to see you back again. COVID will pass. We will have vaccines and life will return to quote unquote normal. But we miss you all. And I want to say thank you to the groups for, in fact, that memory that Kathy has stimulated me to recollect a bit more about that, which was in Houston after the Great Hurricane in 2000 at an early OAA meeting where we lost power in the hotel, and it was close to 100 degrees, and many of the families, there's many children there with organic acidemias, and we were trying to find what rooms they could go into for the air conditioning, and we were giving presentations with industrial strength fans because we didn't have air conditioning. But it was a great meeting. It was just memorable and it was wonderful. And I can just remember meeting Jamie and Manta Petri for the first time, and many of the families that I'm still in touch with today. And it's really wonderful to see all the names in the chat. I'm going to make a few comments as I go through my talk today about the research program we've developed. And I'm just one out of 20. So, and what is amazing, and I'm so proud of, is I'm doing only 1/20th. We have an unbelievable team, and that's why we're making great progress. That and the family support. And I will say this, a little bit more about this as I go through my talk, but I wanted to thank you all for your attention, for having this, for this session. I think it's going to be very, very exciting to continue the dialogue we started. So let me just go ahead and make sure everybody can see my slides. And yes, okay, great.
Yes. Okay.
Okay, excellent. Okay, so let me see how to advance here. Okay. Let me just see here. Yeah, go back. So I think this is just one thing to mention. And again, this is sort of front matter, but as the families and as we as a community work more with our corporate partners, we all should be very attentive to this, that disclosures really are needed. If we present anything that we're doing with companies, or if someone is speaking on behalf of the company, we should make a disclosure. This is my comment to the greater group. And I will go first. And I will say that we've been very lucky to work with many great companies that are helping all of us get new treatments. And that includes Moderna, Translate Bio, Selecta Biosciences. That's in the past. I don't have any active agreements with them, but just to be fully transparent, I want to tell you that they supported some of our mouse studies that we did together. And we have continuing support from Logic Bio and a company called AskBio on different types of gene therapy. But it's in mouse models, it has nothing to do with clinical protocols. But just to say that, I want everyone to know that. Okay, I'm not going to spend a lot of time on pathophysiology and background. It's been covered wonderfully by Dr. Manoli, Dr. Schlotzkov, and Dr. Jordan. But what I will just say is to remind everybody that MMA and PA and organic acidemias have been recognized since the 1960s. And back in the 60s, the phenotypes, the clinical manifestations of what happens to the patients was very carefully described. And it's the same thing we see today. The patients have a severe metabolic problem. They have massive perturbations of metabolites. It's very difficult to treat the children and infants, and the prognosis remains guarded. And these disorders represent a group of many, maybe 100 or more different organic acidemias that are related in some way to MMA and PA, but they have different enzymes that are affected. So they're very important scientifically to stand as a paradigm for all the other conditions. I've said this before, and I've written on this in the articles. One organic acidemia, when you figure something out with that, can help another. And I'm going to show you an example of how we did this for MMA, helping PA for gene therapy at the end of my talk. Okay. So in very, very early days, the patients, these are some of the things that the very earliest days of patient observations made these conclusions. And you can see that I listed them. But one of them that I want to emphasize, because we heard discussions about biomarkers from Dr. Shalotsky and Dr. Manoli, and that's the following. And this is what people wrote in their papers many years ago, that disease progression occurred and in death, despite a biochemical response to the diet. So in other words, if we try to interpret this in the light of where we are now, well, what I would say this tells us is you just cannot just measure an MMA level or any level of any metabolite to make a prognostication. We already know from the 1960s and 70s, decades of research, you can have a biochemical response, but it doesn't always translate to a clinical response. We know that. It's been published. It's been there since the 1960s, yet the discussions still continue to percolate about biomarkers and what are we going to look at and for outcomes for our interventions. It's not that these markers are not valuable. They're valuable, but they just don't prove efficacy. That is one of the things that drives the search for biomarkers and for better ways to measure effects of a treatment. And all of you that are listening, some of you have participated in our research. I'm very, very grateful for that, to help do things like develop isotope breath testing. That's the only test I know of that can always tell if a patient has their liver function of the enzyme working in their liver. Because a patient with MMA or PA can have very high levels of their metabolites. But on that test, they always look like they're normal. So if you just tried to measure an MMA level in somebody or a methyl citrate level or a C3 level in someone who had a liver transplant with MMA or PA, and I'm jumping ahead, you'd never know if they were affected or not, or if they had a transplant. You can't tell. So that's just a case in point example, and it goes way back to the 60s of why we need to get better biomarkers. Okay, so I saw some questions in the chat. I'm not going to go through all these enzymes on this pathway, but you can see this is complicated. All these little boxes, those are all new, different genes that when they have a change in them, they can cause MMA or propionic acidemia or cobalamin C or cobalamin C-like disorder. Very complicated. But we believe if we can figure it out if we can figure it out, let me just try to laser point and look at L. If we could figure it out for say, one, that could help this one, this one, this one, that one, this one, this one, that one. Or if we could figure out for cobalamin C, that would help all of the other ones. You see, this is the plug and play mentality of why it's so important to focus, make the animal models, get really good proof of concept, and then it can help everyone else. So how did we begin? I want to tell you a bit more of a story about background and why it's so important for parents and the physicians to work together. I began, and I'm aging myself here, 1999, I had just finished my training at Mass General Hospital. I was unable to get out of I had to move to Philadelphia because I was on call starting on a Monday morning, and I was trying to leave the Mass General like a day early. What I found out is the most heroic trade I ever pulled off in my whole internship and residency only got me out of the emergency room for 1 hour. I got to leave the ER at 7 o'clock versus 8 o'clock on a Friday night to get to Philadelphia to start my fellowship. So I joined the Children's Hospital of Philadelphia as a biochemical and metabolic genetics and clinical genetics fellow. And one of the very first things that happened in Pennsylvania, and again, around the United States, is in 1999, expanded newborn screening started becoming piloted. It wasn't mandated, it was piloted. And Pennsylvania was one of the places where it was piloted. And there's an interesting sort of historical commentary I could make on this. The point is, I started getting really interested in newborn screening because as the only fellow that year, all the other fellows took a pass or dropped out of the program. There was only one fellow that year. And this is a big hospital. This is one of the biggest pediatric hospitals in the world. The fellow was me. And so when that's you, as a fellow like that, what you do is you do emergency first, second, third, all the way down the list till every emergency is taken care of. And then it's the next thing on the list. And for me, that became newborn screening. Because all of a sudden, I was just meeting family after family after family that had fatty acid oxidation disorders, other conditions, and organic acidemias, MMA and cobalamin disorders and propionic acidemia. In fact, my very first patient I ever took care of on call, the weekend, my first weekend of call as a metabolism fellow, we gathered in the NICU at 5 o'clock, which was sign-up rounds for metabolism, over a patient who had just been diagnosed with cblC. We thought the patient had cblC. It was the very first case we ever diagnosed in Pennsylvania. And we didn't know what was going to happen to this patient. It was the first patient ever described that with a pre-symptomatic diagnosis. The patient had cblC deficiency. And so this was just every single day over, and that's all I did. And I said, wow, this is incredibly important. Inborn errors of metabolism are so important. We have to do something about this, because I was seeing what the clinical phenotype was, because the other emergencies you do when you're on the clinical side is helping patients get to the emergency room, taking care of the emergency room, and managing them in patient unit and ICU. And that's what I did. That's all I did for literally almost a year straight. And it was really, really impactful, because I saw newborn screening and some patients diagnosed without symptoms, which we knew they had a severe condition. And I will also say that at the same time, across the river, when I say the river, I mean in Philadelphia, if you cross the river, you're in New Jersey. And what we were seeing sometimes in the Children's Hospital of Philadelphia were patients that were not getting expanded newborn screening with the same disorders that we were detecting in Pennsylvania. And they were coming in crises and in comas into the emergency room. And then I was taking care of those patients. So I could really see this. And I knew the organic acidemias were so important. There were so many patients that I felt that were being diagnosed, and then the treatments were really difficult. So I started going around to different investigators in the Children's Hospital of Philadelphia to see if they were interested in working on methylmalonic acidemia. Why MMA? I had seen a number of patients with this, and I had helping the families, and I had some very poignant memories of the family saying, I can't believe this. My child has MMA and I'm going to go on a diet that might not even work. That's the treatment. I'm paraphrasing the conversations, but really, it was at that time I said, wow, this is just, I can't believe this. And then at the same time, I was taking care of a patient who had just received, one of the very first patients in the entire world, who had received a liver transplant for his MMA. And I knew I could see this patient. The response was amazing. This kid was really doing, quote unquote, well. He was so much more stable. So I could just see this. And I said, we have to do something about this. So I tried to go around to get people interested in this. The families are the ones that were supporting me, and they were the ones that drove me forward. It wasn't the wise professors. They were the wise professors who were telling me, don't do this, do something else. Until I came across one who was the chairman of the Department of Genetics at UPenn. And then when I got an audience with him, he said, this is a good idea. And that's how it started off. So onward and upward, Excelsior. In 2003, I had a chance to join the National Human Genome Research Institute in the Physician Scientist Development Group. Unfortunately, I ended up giving up my NIH grants, which were very hard to get. So I had to relinquish the grants, but come to NIH to start a program on MMA and PA. It was a unique opportunity to 100% focus on these disorders that we were going to try to, in parallel in the laboratory, develop new models and new treatments. That was the focus of the program. And it was just an opportunity, a once-in-a-lifetime opportunity. I sold my house. My wife was pregnant. We were living in an apartment. I was trying to find a place to live. But that's what you do when you know that's the right thing to do. So I moved to the NIH to start the team. And here's the original all-stars on the team. We have a lot of all-stars, but just the original team was myself, Randy Chenna, who went on over the years and received his PhD. He's a real internationally recognized expert on gene therapy. And Jen Sloan, who is moderating. It should say that she has a PhD in her credentials. I didn't put them on the slide yet, and it was really an exciting time where we would work in the lab. Randy and I were working, actually in the early days, we were working on roundworms that got methylmalonic acidemia and trying to make mice. And then Jen was leading the effort on the patients, and she and I would see the patients, and then Jen started actually working in the lab on zebrafish. So it was really exciting in the very early days, but that was the team. Over the years, we grew. And here's in 2008, and when I'm showing this because I'm very, very proud that we were able to attract really brilliant minds. And you can see here, that's Dr. Manoli. That's when she was finishing her fellowship. So thank goodness she decided to get interested in MMA. And it's amazing. And here's a couple of other people who went on to become a metabolism attendants, Natalie Hauser and Nuria Carrillo-Carrasco. Some of the families may remember meeting the team, but it was a largely female-dominated team. And man, we made a lot of progress. It was excellent. And the team has continued to grow. And here's a picture from last year. I have everybody's name over here on the, forgive me, I'm like not as creative about the displays and stuff. I know Irene had a beautiful slide, but this is what I come up with. But you know, here's everybody. Oleg joined in 2015 and launched the PA protocol, the natural history. And here's some of everybody here, to follow up on what Oleg said. Everyone here is working on some aspect of an organic acidemia, MMA, PA, Cobalamin, 100% effort by everybody. So this is really an amazing resource. We're supported by the NIH and by all the families. And it's really a unique opportunity that we have had at the NIH to really work together, advance the field. And I'm going to try to talk about where we've come over the years. So here's a list of, and I had to truncate this. I can only put the last 5 years of our fellows, and here's everybody that's current. You see Dr. Jordan's on here. He's a pediatric cardiologist. So a real pediatric heart doctor is joining our team. This is amazing. And so he's going to work on gene therapy and cardiac gene therapy and all sort of really cool stuff. We can't talk a lot about it now, but we're super excited to have him join the group. And then also, who's not with us today, but someone who I want to mention is Dr. Tomo Higashimoto, who's an advanced medical genetics trainee and an expert on ex vivo stem cell gene therapy. So we're starting that on the research front as well, and he's leading that effort. And then all the trainees. And then I have the same slide, but everybody in red was supported by Angels for Alyssa MMA Research Foundation, Organic Acidemia, Cure for Clark, or PAF. All those students. And look next to their names. It says MD, PhD candidate. Our students have gone on, without exception, to win the most prestigious scholarships for medical training, including PhD scholarships from the National Science Foundation. And so this is really an investment. And so this is all part of this program that we're all helping. And this is the young blood. These are the ones who are going to come on and be the next generation. And they got their training on MMA, PA, and Cobalamin C. It's an amazing accomplishment for the group. And it's all the team that's mentioned. I help, but it's a team effort. Okay. So we've done a lot over the years, and I'm just going to show you. I can't go through everything, every single little thing that's popped up here. That could be a separate lecture. We just can't go through all that. It's just been amazing the amount of things we've been able to accomplish as a group focus. Starting with our natural history studies and all the way, and looking at mice and looking at diet and looking at new genes and looking at pathophysiology and looking at treatments. And this is where we are in the last couple of years, where we've made new models of propionic A and B deficiency in mice and zebrafish. We've made new models of cblC mice. We've started a program with NCATs. We are participating. They are leading the effort called PAVE-GT. I'm going to talk to you about that. Recently, Jen has had an amazing paper on zebrafish that get cobalamin C. I should also say, we are very grateful for the, when I said before about the students, the Rockford Retina Michael's Klapsich, the Retinal Research Fund helped us. I should have said, I forgot to mention that before, but that they helped support our efforts and our students on zebrafish. And we're very, very grateful for that. Funded one of our students, and that student, he may even come back and become a medical geneticist. So that's amazing. But anyways, that paper just came out, and that's been an amazing accomplishment. And it's really interesting for the families. If you want a real technical read, that's available. And then we also just recently had a major paper on a new treatment for MMA. using genome editing, which I'm going to talk about. It's called GeneMed. And then we have had a number of other things that are under development, which I can't talk a lot about, but just to show people, and I'll be glad to talk about in the Q&A, some of the things we're working on. And this is only a partial list. So in aggregate, I was just reviewing sort of some of our statistics, so some people might wonder about this. We've had about more than 1,200 patient visits. We have from those visits, and again, echoing what Dr. Shalachkov mentioned, from all those visits and over the years, we've have about 100,000 different samples in our biobank. And this is amazing. This allows us to go from a mouse that we think has something and then say, oh, well, maybe the patient has it. We can check the patient and see, oh, a patient with a certain, say, renal symptom, and then they have this high level of this hormone, just like the mice. And this is how you really can find new biomarkers and then validate them at the same time. And I want to thank all the patients and the moms and dads for donating blood for that your samples are part of this biobank, which we have used for research to make better treatments for MMA and PA and cblC. And overall, we published many, many papers, more than 100 on all of our observations. So I can't go through all this, but this is all part of this program of research that is in some ways sponsored by a tiny little bit from the government budget, government spending, and then also all the families who supported us for this. All right, so why are MMA, PA, I'm going to mainly focus on MMA and PA now, so difficult to treat? This is going to be a little technical now. I'm just warning everybody. It's going to be highly technical for the next couple of minutes, okay? Why are they difficult to treat? That's what you have to step back and say to yourself. Why is it that some conditions, like PKU, you could go on a PKU diet and I will say be completely unaffected, but no one really wants to go on PKU diets aren't so palatable. If anybody thinks they can drink a bottle of PKU formula, I'd like to see it. They don't taste so good. And I've tried the MMA and PA formulas as well, and they're about equal in their taste. But to have to drink that and say that's your whole life, but for a patient with PKU, if you just took your diet and you did that, it would really be miraculous. You would have all this sort of neurocognitive effects, everything would be so much less. MMA and PA, that's not the case. I just went through this from the 1960s. When you change the diet, lower the metabolites, you still have it's very difficult. It doesn't respond to just dietary management alone. Why? Well, one of the reasons it relates to intermediary metabolism and where the enzyme defects are with respect to the way the body processes the way the body processes amino acids. And that the way that happens at a global level is first the amino acids. I've been showing. Let's see if I can get my laser work over here. These are the amino acids, isoleucine and valine. A lot of families know about those. They can sort of interchange in and around the cells until they go through this reaction here, the branched chain alpha keto acid dehydrogenase reaction. Because once that reaction happens, it's irreversible. This is like for those who ride the metro. If you go through the one-way gate, you can't turn around and go back. It's like a one-way valve. You can only go one direction. And so once that happens, whatever came in at the top, you have to get rid of it. I mean, I say the body, we have to get rid of that because we can't back metabolize. We can't convert the intermediates and go around this step. Mammals can't do that. That's why this effect of fixation of metabolism, which then drives oxidative metabolism and produces all sorts of downstream effects. But that's one theoretical reason why these disorders are so difficult. You can't modulate the diet easily at the top and keep reversing the compounds because they come from beyond the block, beyond when you generate them, and you can't go back. That's why it's so hard to treat this. One reason. Another reason, and again, this is theory. So I'll hopefully in the Q&A I can come back and revisit some of this. But there's another reason why. Here's a slide, and one of the great things that I'm proud of is when you have excellent colleagues like Dr. Manoli, you can borrow their material. So I took some of her slides and I repurposed them. So thank you, Dr. Manoli. So here's a slide that she showed, and I just jazz it up a little bit here to show some of these things that we talked about, which is where these metabolites come from. Will mainly come from amino acids, from the gut, from odd chain fats. And these are some of the metabolites we've talked about. And you have a PCC, that's propionyl carboxylate, that's the PA block. You'll produce these metabolites. If you have a block at the mutase step or your B12 problem, you produce MMA. And then these are the downstream effects we talked about. You can get reactive oxidant stress. That's what ROS is. You can get glutathione deficiency. You can have an effect on the electron transport chain. The real problem is this. A lot of these metabolites are endogenous. That means they come from within. So if they're constantly coming from within, it's very hard to try to manipulate that and control them with diet. You can lower them. I'm not saying that you can't. But there's this constant production. And that's another big challenge in these disorders that make them very difficult to treat. The source is just always on. It's like it's an on switch. It's always on. You can't turn it off. You can turn it down a little bit. You can modulate it. You can't turn it off. And you always produce the metabolites. And if there's just the metabolites, there's even more to say about that. That's another reason. And the last reason, and this is a real theoretical reason, so I'm just not going to spend a lot of time on it. I'll just mention it to you. Is something called cellular autonomy. And it can be further caveated by calling it conditional cellular autonomy. And what that means is that certain cells within the body, under certain circumstances, have the propensity to have the metabolic injury syndrome. So in other words, here's an example. You could take a mouse, for example, MMA mouse, and you could take the MMA mouse, you take its liver out, and you can take its kidney out, and you can look to see, well, where are the cells that are having difficulties? And you can find the cell, the hepatocyte, or in the kidney, the proximal tubule. And then you could take that same mouse and take its muscle out. The muscle won't have any problems in the mitochondria. It's because there's an element of autonomy of the specific cells that are being affected. And that has implications for therapy and pathophysiology, which I'm glad to further talk about. On one hand, it's good because it would tell you, on one hand, if you correct something, the cell might be resistant because it's autonomous. In other words, it's to itself. Once you correct it, it doesn't care what's happening next door. And we know that's the case from a mouse model Dr. Manoli made and published in 2013, where we make mice that are essentially born with a liver transplant. And we can take those mice and feed them enormous amounts of high protein diet. You heard Dr. Jordan mention that. So just give them a huge, it would be like, imagine having a person, all they eat is meat and milk and cheese and pizzas, and that's just all they ever eat. Mice, we give the mice the same thing. It's a casein enriched chow. So it's a milk protein and the mice just love it. Except it turns into MMA, PA, organic coenzyme A derivatives. And those mice, when they have that new liver from genetic engineering, their livers are perfectly fine. But the kidneys get damaged. And Dr. Manoli further went on to show in that paper that she had developed a regimen using a combination of antioxidants and vitamin E to slow down the kidney. This is an example of how you can use small molecules. You can slow down the kidney disease. You can't get rid of it. You can slow down the rate of progression. And it really works in the mice. It's one of the only examples I know of that's been published where there's really a real experimental model where someone says, okay, here's a small molecule. Here's a disease model. What's the effect? In an animal model that gets it, not in a cell or not in an enzyme reaction tube or something, in an actual model. So this concept we'll come back to maybe later, but that's yet another reason. That could be pros and cons. I just tried to illustrate why that's the case. Okay, so treatment approaches, where are we at? I just talked about diet and manipulation to medical foods. I've said that again and again. Since the 60s, we know this is not going to do it. Gut sterilization. This is again a way that first was done in the 1970s. Whether it's going to work, whether there's side effects, whether there's risks, unknown. Whether it changes clinical phenotypes, unknown. It's still used. Some patients still take 1 to 2 times, maybe once 1 week per month. They can take metronidazole, these other alternatives, Flagyl. That's the other name for that one. What's the clinical effect? Unknown. There's small molecules. We heard about those. A lot of people take carnitine. To my mind, there's never really been a real clinical trial study that's proven that that's efficacious. Or antioxidants or carbon glue. And I'm not saying them not to take them. It's just that's where we are with the therapies. This is a problem for rare disease space in general. We're not going to do a randomized clinical trial with thousands of patients with all these different medicines and see, look at effect sizes like you can do for blood pressure medicines or lipid medicines. You can't do that. Yet this is where we are. And I'm not saying that I don't think those things work. It's just, if someone was really critical to say, what's the evidence for that? It would be a discussion about what is the real evidence? Does that really prove it? The next things I'm going to talk about are theoretical. Gene addition therapy, which has the potential to correct the cell. Remember this thing about autonomy I just said. You're going right after it. Skip over everything else. Go right for the enzyme. And there's different ways to do that. You can do AAV. You can give the RNA, that's mRNA therapy. And then you can do genome editing, which I'm going to talk about also. So now we're going to get right into the real meat of it. It's going to get a little technical. So just buckle in. We're going to go through this. Okay, so the treatment approaches, we just went through these. Dr. Manoli had a beautiful slide on it, but what you're doing with the enzyme replacement therapies and the gene therapies is you're going down over here. You're just trying to give the enzyme some fashion directly. And we know that in many studies over many years, when you do that to the cell, it fixes the cell. Okay, so where are we at with AAV gene addition therapy? I'm going to start off with this. This is gene therapy. We're getting into this. It's going to be another little story I'm going to tell you in a second. So what is this generally speaking? It's a transfer of genetic material into the patient's and the body and the cells in the patient. Usually you do it to introduce a gene. That's the first thing. You can also do it to change or correct a gene. That's a permanent thing. That's editing. The two women just won the Nobel Prize for sort of working out the CRISPR-based editing. Super exciting and excellent. It's just amazing what the Nobel Prizes ceremony, I think, is going to be in a few days. Hopefully it's going to be live streamed or something like that. Jennifer Doudna Charpier won the Nobel Prize for this idea, which here's an example of basic science. What does that mean to me? Well, that could actually mean someday reconfiguring that technology that those women helped pioneer and invent to a treatment for MMA or PA. That's the real implication of it. Amazing. So we're not there yet, but it's something we might get to. And then there's another way you can use gene therapy to knock a gene out. Say there was a gene that caused a person with PA or MMA to make them a lot sicker. And say it modified their phenotype. Then you could try to knock that gene out, get rid of it. Maybe it would make them better. We're not proposing that for MMA and PA yet, but there's ideas about that I'm not going to talk about now. Okay. So here's another example that I thought it would be worthwhile to share with the group and the families. Because people talk about gene therapy and, who's the first person to get it and what's the history of it. Well, the very first person to ever get gene therapy, as we think of it, in some ways, were two girls with arginase deficiency in the 1970s. And someone had isolated a virus from a rabbit, the Shope papillomavirus. Papillomaviruses, as we think of them, are associated in humans with things like head and neck cancer, cervical cancer, warts. That's the type of virus it is. This came from a rabbit. And what they noticed in the laboratory was that people that were working with this virus had lower levels of arginine in their blood. So they surmised that this virus might cause an increase in the ability for someone to metabolize arginine. So they prepared this virus at Oak Ridge Laboratory. Here you can see right down, that's in the United States, it's a big research lab. And they injected this virus from a rabbit into these two girls who had neurocognitive dysfunction. They didn't respond. It's never going to work. But this is what was done in the 1970s. So at that point, there was a real, many articles and a real resurgence in the field of recognition of, what's the process for this going to be like? And a lot of articles came out. This one's a really famous one, human gene therapy for human genetics. It's still relevant to this day. But just to say, when you look way back, in some ways, almost like as we look back in the history of patients with organic acidemia, in some very early studies, babies were getting infused with radioisotopes to try to figure out, say, the half-life of MMA. That's how it was determined. So times have changed. I'm here to tell you that times have changed. Well, we care now, number one priority of all studies, safety. Safety, safety, safety. And there's been a huge change in the field. And we're never going to do anything like this. I'm just showing it to you out of interest. I thought people might learn something about this old experience, because every experience that we have in the past always helps shape how we do things in the future to make them better. And this is the very first step, and things have come a quantum leap, many iterations for FDA regulation, safety. But in the very beginning, this is really probably the first example of gene therapy. Okay. Fast forward decades and decades, and now we're doing something with, a different sort of a virus, something called an adeno-associated virus. This virus in nature is thought to be non-pathogenic, means it doesn't cause any known diseases in humans when it's in the wild type state. What you do to make a gene therapy vector from this is you remove every single scrap of nucleic acid, every base pair, literally almost, from the virus, except the absolute minimum that it needs to be packaged. So when someone makes an AAV for gene therapy, it's not a regular virus. It can't replicate, and it can't do all the things a regular virus can do. It's been, all those genetic determinants have been gutted out of it, and you put your gene of interest inside of it. That's what you do to make a vector. And when AAVs are configured right, and there's examples of this in dogs and in monkeys, but a single injection of one of these AAVs configured with the right gene, say in the case of hemophilia, the gene can be expressed for as much as a decade, a single injection. And they've been used in humans. And there's even 2 FDA-approved therapies that are AAV-based. One's called Luxturna, the other one's called Zolgensma. That's for SMA type 1, spinal muscular atrophy type 1. And the thing about AAVs come in different serotypes, different flavors, different coatings. So you can see here 1, 2, all the way up to, there's actually 13 sort of main types of AAVs. And the analogy here that I want to make to the families, and this is again a technical one, but think of this like the flu virus. Every year you got to get a different flu shot, right? So because every year there's potentially a new flu virus. So when you get one type of an AAV, that's like a new strain. So AAV9 is one type of an AAV, AAV8 and everything. But each one of them, the type of the outside of it, the coating, the so-called capsid, that makes that AAV, it gives it special biologic properties. Like here's an example. An AAV9 is one of the ones we like to use in mice and probably in patients. When someone gets this by an injection, like an IV injection, the AAV will go into their liver, but it also penetrate and transduce the heart and the skeletal muscle. And if you give enough of it, it'll actually go into the brain and transduce neurons. And even if you give even more of it, it'll transduce nerves in the spinal cord. And that's how it works for Zolgensma. It's almost magical in some ways how these properties exist for these different AAVs. Now, other types of AAVs, if you change the coding, they can't do that. They can't penetrate the brain. They might have a better ability to land in the muscle or the heart or the liver, for example. So this is part of what, when someone makes an AAV therapy, it's what's inside of it, then what's the serotype. And there's even another way that you can engineer the serotype. It's a very interesting area where you can actually custom engineer synthetic AAVs that never were in nature. You could create them in the laboratory and then make them into gene therapy vectors. And we've done that actually. And one that we've used is super potent. We've worked on with a professor from Harvard, Luke Vandenberg, who invented this synthetic AAV, and we reused it. It's really effective in mice. So when we take these AAVs, what we do is we benchmark. So we try to develop a therapy and we say, how good is it? And so when people think about benchmarking, think of it this way. If you watch football, how fast can someone run a 40-yard dash? Or if you're an auto into cars, how fast can someone go from 0 to 60? Or how many miles per gallon does a car get? Like these are benchmarks. And so for AAVs, we can do the same thing. We can benchmark. And the way we benchmark them is we say, how good is it at what dose to fix a really sick mouse model of either MMA or PA? That's how you benchmark. And then if you have something you think is better, you got a car that's better, it gets more gas mileage. Okay, what's the gas mileage? One is 38, one's 40. Which one's better? Well, the one that gets 40 is better, right? This is how you can benchmark. I'm simplifying it to make the analogy because it's a little more complicated than that, but that's the idea. And we've done this many times with all different types of AAVs. Here's just a couple papers. Randy's really been a superstar leading this effort. on AAVs in mice with MMA and PA. And so we know we can do this. And what does it look like? This is what it looked like. Here's an example. Here's a sick little MMA mouse. We've been babying this mouse along, giving it sugar water, heat pads, special diets, injecting it with saline. You can see it there in the upper left. It's a sick animal. It has MMA with no treatment. So what ends happening to those mice? Normally they die on the first to second day of life. Now, there's a way you can change the genetics. I'm not going to explain this. We wrote a paper on this. But with certain genetic manipulations, you can get these mice to live a little bit longer. And this mouse lived to day 32 because after this photograph, it actually the next day was found dead in the cage. That's the type of thing that would an MMA mouse or a PA mouse would have. They have very limited ability for any type of stress, manipulation, handling, fighting, wet cage. That's going to kill the mouse. So that's what the mouse looks like. Now, when we take this mouse, imagine that mouse when it's just born. And a newborn mouse, imagine 2 or 3 pencil erasers put together. They weigh about 1 gram. So a big size of it, like a gumdrop or a jelly bean. That's what a newborn mouse is. So Randy goes down and he can, boom, right inject them right in their livers in a second. And when you do that, this is what the mice look like. The mice over here, these mice, that mouse is methylmalonic acidemia. Very high MMA levels, around 300-400 micromole in these mice. These mice are close to a year of age too, by the way. So with a single injection, you can do this. Here's a benchmark, right? So if you have a treatment, how good is it compared to this? Now, this is not the treatment we're going to bring into humans, because this treatment we learned has a complication related to AAV, the way the AAV vector was designed, which we solved over the years, but it took some time. But it's a way to benchmark. So the very first thing we did after we did this, the PA mice, there was an extreme difficulty doing the same study in propionic acidemia. So we said, well, we have it. We have this benchmark approach. Let's try it in PA, see if it works. Guess what? It works in propionic acidemia. One organic acidemia helps another. We developed this for MMA. We just changed the cargo, and now it works on PA. And here's the paper that Randy wrote on that. And here's an example. I'm going to walk you through this. And again, we published this in 2011. So this is what happens to the PA mice. Down here, this is survival. So how many are alive? They don't get any treatment, 100% die. When Randy goes in and injects them with this AAV we made, very similar to the way we did from the MMA. Look, 50% of those mice are now alive. That's amazing, because these mice are very, very sick. And then you can take their livers out. I mean, these are things we do in mice. And there's this little black band over here, this spot. That's the enzyme. That's a propionic-CoA carboxylase enzyme. You can see it's a lot. There's a lot of it. That's a wild type mouse. It's about as much as a wild type mouse. And it goes down over time. And there's a reason for that. But that's what's keeping the mouse alive. And you can measure it and say, look, what happened to the levels of the metabolites? The levels went down. Levels went down. Enzymes expressed. Mouse is alive. Benchmark. That's how you do it. So now we've done this, and I can tell you, I'm not going to go through this. We've made all sorts of new mice with propionic-CoA carboxylase A, all new vectors that were different from this one. And then we benchmark them against this and see if it works about as well. The answer is it does. That's the one you give to a human. Ones that you've redesigned them for safety and better serotypes, and they work well on the mice, benchmark it against the standard. That's the one you advance to human clinical trial. And that's exactly what we're doing through this project. And I would appreciate it if somebody, maybe one of the moderators, could put this website, this link into the chat for the families. It's a project. And of the 1,000 or more research groups at NIH that are working on all types of conditions, our group was selected by NCATS, the National Center for Advancing Translation Science. They are going to take 2 of our disorders. We couldn't, I would pick all of them, but we could only pick 2. And it wasn't all 100% my decision about exactly which one. But the disorders we picked are PCCA and MMA-B. And so for those disorders, NCATS with us and there's another investigator from NIH who's working on neurologic indications. We are going to make I'll call, for lack of a better to simplify this, I'll call it an open source platform for gene therapy. But that's going to include a clinical trial for these disorders that we can do at NIH. And NCATS is going to do all the FDA interaction, manufacturing, toxicology, and we're going to make that available to the community so that the next patient with an organic acidemia they want to get help with their condition, they can use our model. They can use our template. They could use our interactions with FDA that companies usually are very, very secretive about to help them get their treatment for their condition. It's open source. And we are very, very lucky and fortunate that NCATS has selected these projects. And the good news is that means there could be a gene therapy treatment for PCCA and MMA-B deficiency. And what I can tell you for all the other families, if you don't have this, we have developed almost identical therapy for PCCB deficiency. It's just not going to be in this project. And also with mutase deficiency. We also have gene therapy for cblC and MMA. So we've done it for most of the conditions. But these are the ones that are being picked for this project from the government. The federal government is picking these. And this is amazing for us, the organic acid research community, to have these conditions be selected to go forward for a new treatment and gene therapy. And they're paying, see, that's the other beauty of it. There's finances here, right? You can't just go snap your fingers and do this. This is a serious, serious investment of, just imagine, this would normally, you'd have a company would have to do this. And you'd have to have funding and all that stuff with companies. Government's doing it, NCATS is doing it for us, and we are working together with them and with the community. And I'll be glad to talk more about that in a minute, but this is a huge advance. Okay, RNA therapy. What about mRNA therapy? People have heard about this one. Well, we were fortunate. We worked with Moderna. Moderna is a company that is, you've heard them in the news for the COVID vaccine, but they also work on other things, including before COVID, they were working on methylmalonic acidemia. They were working on a lot of different things, but this is one of the things that we did a project with them together. And you can see here, this is one student who was in my lab. She got her PhD in this area. And then there's me, and then there's Dr. Martini, and then other members, there's Randy, and other members of the team. We all work together on this with Moderna. And the way this works is they have a special formulation, a lipid nanoparticle. It's called LNP. And this is like a little, it's not a virus. It's not alive. It's not a biologic entity in the sense of antibody or virus, but it's like a little shell of lipid. And inside that little shell, there's RNA. So this is the stuff that immediately becomes the protein. With a virus, usually you go from DNA, then it makes the RNA makes the protein. This is the RNA that's in this little particle, and it's the RNA for the mutase enzyme. And so what happens when you give this to a mouse, and hopefully in a human, that hasn't been done in a human that I know yet, this little particle goes to the liver, it unloads the RNA. The RNA then gets expressed inside the cell, makes the enzyme, and the RNA degrades. The enzyme stays behind, is made, and it's active, and then it eventually wears off. And in mice, it wears off in about a week or something like that. But when it's on, it really works. The mice have lower metabolites, and they can oxidize propionate. There's other things in this paper, you can read it. It's really, it does work in the mice. It's transient. And so here, I'm just going to show you what I mean. When here's this is not from Moderna. This is another. There's other people working on lipid nanoparticles for this as well. So here's an example. When you take the mice, take the liver out, this little green band. So we get, this is not the Moderna preparation. It's a different one, but it's the same idea. You give these mice no treatment. They don't have any of the enzyme. When you treat them, all of a sudden they make the enzyme in their liver. And then what happens is their levels go down. They stay down. They start to rebound after the treatment. And then also there's one for propionyl-CoA carboxylase deficiency. And this is a different one that, again, from the Moderna group, just published this one. And here's the citation if you want to look it up. And in this article, what they do is they put both the A and the B subunit into one particle. So in theory, if you didn't know what type of propionic acidemia a person has, A or B, but we know in our study, everyone knows. But if you didn't know, you could just get this and it would treat A and B type. And what they'd show in their papers, it treats the cells and they treat a mildly affected mouse. So this is not the severe mice that die right away. These mice have a very, very mild form of propionic acidemia. But when they give this particle to those mice, the mice have a biochemical changes. So it looks like there's a signal for this working. And again, it's going to be temporary because the RNA makes the enzyme and the RNA degrade. But nevertheless, there is a clinicaltrial.gov trial entry on this out there somewhere. The next one is editing. And this is a different type. This is going to be a harder one to understand. I'm just, again, warning the audience, this is a tricky one. And this is AAV-mediated nuclease-free genome editing. Okay, so what does that mean? I'm going to try to walk everyone through this, what that means. So what that means is you use the AAV, and I'm showing you this little cartoon. This was done with Logic Biotherapeutics. And we did a lot of the experiments in my lab, and they also did studies as well. You can make an AAV, instead of the AAV being designed to express your gene, the AAV is designed to integrate your gene of interest into a specific location. And the way this works is that on the other side, so to speak, the upstream and downstream sides of the gene of interest, you put homology arms. So that's a homology arm is like almost like what it sounds like. It's going to match up with the DNA in a cell. It's going to find that DNA and say, hey, I'm very much like you. I'm going to line up with you. And then that's what happens in the cell after the AAV uncoats the genome. And then the DNA template that's what's provided by the AAV for this reaction that the cell does on its own. The AAV doesn't do the reaction, the cell does it. And then by recombination, you can see here, this is this little cartoon. All of a sudden, this thing, I'm skipping steps to make it easier to explain, integrates into the genome, right at the location, in a specific location at the exact base pair, at the very end of albumin. And albumin is a protein made in our livers. It's expressed at very high levels in the liver. So what's happening now is that cell that gets this event to occur makes a huge amount of the enzyme from the control of the albumin promoter as the fused RNA. So the RNA contains the albumin. It contains this little thing called the 2A peptide, which mediates what's called ribosome hopping, and it has the mutase enzyme. So what happens is the ribosomes come along. That's how you make a protein from an RNA. And they get to here and they go, oh, they think they're at the end, but what they do is they jump over and they make a hop to the mutase gene and make a separate protein from it. So from this RNA, there's two proteins. This, which has the 2A on it, and the mutase enzyme. The mutase enzyme then in turn goes into the mitochondria, and it works. How do we know it works? We tested it in mice. That's how we know it works. And here's how you test it. You treat the mice with these different an AAV that, like I said, the AAV we used in the mice is only going to work in mice. The one we did in mice will not work in humans because it has different homology arms. But in the mice, it's the exact same idea. It's just a different DNA sequence you put on the homology. And what you see in the mice is that this, again, we're taking their livers out and measuring the enzyme. That's that little black band over there. That's the mutase enzyme. 1 month, there's some have a little bit, some have more. It's increasing. Then, wow, look what happens here. 13 months, 14, lots and lots of enzyme. How could that happen? Well, we took their livers out, and what you do next is we can stain the liver and look for the cell that expresses that enzyme. And what you can see here is these little clusters of cells all throughout the liver. Each one of those cells is making that, the brown staining, that's the RNA for the mutase enzyme. So this liver is loaded with these little cells that are making lots and lots of enzyme. So then the next thing you would want to know is, well, what happens in the control animal, the litter mate that doesn't have methylmalonic acidemia? What does that animal look like? That's treated exactly the same way. That animal looks like this. That's very, very few cells. The reason we think, we're pretty certain about this, is because when this event occurs on this side of the screen, it's a rare event. It's a low frequency event. But when it occurs, the cell that gets that, because of autonomy, remember I talked about autonomy, now can grow a bit better. It's probably that the other cells are dying fast and this one just keeps growing normal. That's probably what's producing what we think is a growth advantage. It's growing better in the MMA environment. But I can tell you that none of these mice had any hepatic abnormalities of the hepatic histology in this corrected cell area. So they didn't, this wasn't like a malignancy or something like that that was causing the cell growth. This is because the cells have the mutase enzyme. It's functional, it's protecting the cell. And it's growing when all its neighbor cells are having a difficult time because they have methylmalonic acidemia effects in that specific cell. Autonomy. This goes to autonomy. So what this means, the implication of this is that if a person got this and it worked in a human, if it worked, that the number of cells might increase in that person over time because of a selective advantage of this growth advantage. Now the differences are this: in mice will have many, many times the effect of a human, the growth advantages, because their livers have a doubling, what's called a doubling time in a mouse. Mice have many more doublings than humans have. It doesn't mean that it wouldn't have an effect in the human. It just that means in the mouse, there's this effect on the mouse the physiology of the mouse that could be, we could be seeing this could be more pronounced in the mouse, for example. We just don't know. But it's very exciting nevertheless. Okay, so if we make a summary slide about the newest treatments and where they are, I'll just make a couple comments. And I want to say this too. We are not a site for any of the new proposed clinical trials. So if anyone wants to say, what about this? Can I enroll? I can't answer. You're going to have to go to your referring physician and get their information. I'm not a site. We are not a site for any of the RNA or logic bio. We're not a site. So I can't make any comments. I can only just tell you what's been published in the literature. mRNA therapy for these conditions. It's IV. Okay. Interval. It's unknown really, but if a person is going to get this, and if it only lasts 1 to 2 weeks, you need to get an IV. Every 1 to 2 weeks, you get a new infusion. Now, there's other ways around it, right? I don't want to get into that. I'm not, someone who's running the trial would need to answer that, but it's IV. It's not a pill. It's not an injection. It's not a tablet. It's not something you put in your G-tube. IV. And it's a lipid nanoparticle. I think I told you this, and it gives the RNA into the liver in the spleen. Could it have side effects? Let me just say this loud and clear. Any medicine at all can have side effects. Doesn't matter if mice didn't have it, monkey didn't have it, doesn't matter. Anything can have a side effect. Can it have a side effect? Yes, it can. Gene writing, editing, that's the editing one. How do you get that one? IV. How many times? Once in a lifetime treatment. What's going to happen after you get the IV? In theory, some amount of the virus that is given is going to integrate, like I just showed you, like happens in mice. Targeted integration to albumin. Side effects, are side effects possible? Yes. Regular AAV. Canonical AAV. How do you give that one? IV. How often can you get that? Once. The reason you can only get that once, and with this one, gene ride, is because we think, we are absolutely pretty certain, I would bet anything on this, that a person will make antibodies against that AAV. And once you make antibodies, you can't get it again, ever again. Well, I could discuss, there's a theoretical way you could get it again, but practically no, you can't get it again. Could it, how would this work? Depending on how you've made the AAV, this one could work in the liver, muscle, heart, brain, eye, anywhere that AAV goes. Really good for organic acidemias because we know from mice and patient studies, these enzymes are expressed in other places other than the liver. The liver effects are dominant on the physiology and on the phenotype, but the enzymes are made all over the place. Now, for some indications, that could be bad. That could cause what's called off-target effects. If you only had an enzyme that only was in the liver and you were all of a sudden expressing in the liver, the muscle, the spleen, that's no good. You could get an off-target effect. And in these disorders, we know, we've studied this. These enzymes are made in the kidney, they're made in the muscle. What I just said. Possible side effects? Yes. Small molecules. How are these going to be given? We think oral, we don't know. Probably oral. How often? It's unknown. Probably at least once a day. There are no publications that are out there that provide any insight about anything about the newer small molecules. I can't say anything about it. There's just nothing available. Side effects, I just told you. Anything can have a side effect. Side effect possibility? Yes. All new therapies can have side effects. Okay. The question is going to be, what's the profile in the patients? What's the nature of the side effect? Is there an interaction between any of these things and the disease state itself? The answer to that's going to be yes, by the way. So can any of these new therapies, could they have side effects? Yes, all of them could. What they're going to be is a point of discussion and some speculation. That's why you need to do studies in mice and monkeys and et cetera, et cetera. But even then, and I'll say it again, that doesn't mean that it won't happen in the human. So you could do something, it'd be perfectly fine. The monkeys get nothing, whatever. You know? But in a human, it could cause a side effect. That's well known. This is why phase 1 trials are about safety. Okay, so I'm not trying to end on a negative note. I'm very positive about all these things, but I just want everyone to know that we have to just be cognizant of what a phase 1 trial is and about new therapies going into humans. Side effects are something we pay a lot of attention to because it's just an unknown. So with that, I think I might have gone over, but I keep this painting or this drawing just to the families. If you ever make drawings or figures for us, all of us really like them and we cherish them. I keep this one on my door. Okay.
All right. Thank you. Thank you, Chuck. So I'm going to just throw out a couple of polls before we do a Q&A, especially since he kind of talked about some of the treatment options to see. I'm going to get this question. If these were available, any of these treatments, how would you participate in any of these therapies? Can you see my polling? Just interested in seeing, obviously he, more detail from the pharmaceutical companies could maybe give a little more detail, which we're hoping in the new year to possibly offer more information from the pharmaceutical companies as the clinical trials move forward. So I'll give a few more minutes and see how people react. Okay, going to share those results. So sounds like people are half and half interested in the two therapies that are promising. I just put out there, if any, what is a gene therapy? If people know, after Dr. Venditti's talk, you might know a little more about what a gene therapy is. But this question I probably should have asked before he started, but. I think a lot of people probably understand it a little bit more now. And there's the results. A lot of people understand. And you did a good job, Chuck. Not too technical. So that's good. So let's see if I had any other questions.
We're working to make it available more than once in your lifetime, but that's in progress. Yeah.
Yeah.
For now.
Okay.
For now, it is
possible.
Yeah.
So anyway, we'll just spend the next few minutes going through some Q&As, and Jen is going to walk through some of those and try to answer some of your questions. Hopefully she either did it in the chat area or we'll do it live now. So go ahead, Jen.
Yep, I've saved a bunch of questions for the Q&A and then sent some back in the chat. So if there's any that we don't answer, feel free to email me and follow up. and I'll post my email at the end. So I thought maybe we could actually just start with the questions for Dr. Venditti's talk, since there was a few of those, and then go back to the other ones, if that's okay with everyone. So Dr. Venditti, the first question is, would a patient that has already had a liver transplant still be a candidate for gene therapy? And is the liver transplant considered gene therapy?
So the answer to the first question is the first generation of gene therapies that are being developed now would probably exclude patients who have received a liver transplant. It's not to say that we aren't developing ones that could be used for all patients, because we are doing that. But in the first wave, a liver transplantation will probably be a contraindication for participating in the trial. The second question is, I'll say it again, is liver transplant considered gene therapy? Some people have used the word surgical gene therapy to describe liver transplantation. What it does, it technically is not gene therapy.
All right, and the next question is sort of related to that. Does gene therapy have the same effect as a liver transplant? And then the same question about mRNA. So how basically can you compare gene therapy to an mRNA to liver transplant?
The answer is yes, you can do that. But the problem is, and the caveat here, and there's a very big one, which is person who gets a liver transplant takes a lot of other medicines that a person that gets a gene therapy or an RNA therapy is not going to take those immune suppressive medicines in the first imagination of how this would work. In the beginning, there were, at least for gene therapy, there will probably be what I'll call transient immune suppression. So there's, in terms of the metabolic effects, they would be comparable in some applications. For example, liver-directed gene therapy. Can you compare that to a patient with a liver transplant? That would be the ideal comparison in some ways. The problem is, again, what I just said, it's confounded by the fact that the person with the liver transplant takes a lot of other medicines, and that can make the comparison not perfect.
And what about mRNA therapy? How does that compare to a liver transplant? And then someone else is asking, mRNA therapy, why is it so fast?
Okay. Well, mRNA therapy really doesn't compare per se to a liver transplant because it's transient. So with mRNA therapy, you get the IV, it's going to go in, the enzyme is going to be made from the RNA, then it's going to disappear. So it only lasts, what's being made from the RNA lasts inside the person's cells. And we know for mice, with the half-life in the human is not known. In the mice, you can look at the paper that I give the citation for. That was looked at in the mice, and there's been another paper that's looked at that carefully. And again, you have to be, the mouse models are not, there's caveats to extending the half-life observations from a mouse and making a jump to the human. But it's transient. So it's not really comparing, because a liver transplant is permanent. It's that, the enzyme is always there in every cell, it's always on. With RNA therapy, then that's not the case. It's only going to be there when that RNA is made, the enzyme, for that window of time, and then it's going to go away.
Okay, another sort of related question is, how about the gene therapy? Does it correct the MMA problems in the liver only, or can it correct other tissues in the body? So
then again, the answer is depending on the vector, depending on the type of AAV, the way you design it. If you make an AAV, a vector, I'll use the word vector, that's the delivery, the therapy, that expresses in multiple tissues, there's ways to control the expression of the gene. And that's usually at the level of transcription, which is how when the cell makes a decision, am I going to turn this gene on or off? And so what typically is done, and there's sort of two flavors for this in the setting of metabolic disorders. You can either have a transgene or a vector that only works in the liver. So that AAV is going to go all around the body, for example. but it only expresses in the liver. That's one way to do it. There's advantages of that. And that's very much like the liver transplant analogy. The other way is to use what we would call, and again, this is just another word, a constitutive promoter, or a promoter that's always turned on. So whenever that AAV or that vector goes into a cell, carrying its cargo, which is the mutase enzyme in this example, that cell then makes the RNA. And we've published lots of papers on this. And constitutive promoters work well because they express at low levels in the liver. And you don't need to have very, very high levels of expression, by the way, of this enzyme in the liver to get an effect. And anywhere else they land, they're going to express. So here's an example from propionic acidemia. Ideally, what you would want is a treatment that expresses in the liver and heart. And so we've actually developed such a vector that's the one we're going to use in our propionic acidemia studies. And it does not use a liver-specific promoter, but it expresses in the liver, but it also expresses in the heart and the muscle. And can it correct other problems? We're in the process of determining that, but the answer is yes, it should.
Okay, next question. How can AAVs get across, like, to the brain through the blood-brain barrier? And have you been using BBB shuttle peptides? Very nice.
So that's a really advanced question. So how AAVs can get in, it depends on the species, it depends on the capsid. AAV9s in mice have a certain way they go across, and it's a receptor-mediated process. With AAVs, only certain serotypes can get across the blood-brain barrier. Not all of them can do that. AAV9 can. So what right now we've been doing in the first approximation is using natural serotypes and engineered natural capsids. That's something separate. To that have increased ability to transport across the BBB. We have not, what you're suggesting, or whoever, I don't know who wrote that, that's very sophisticated. We have not done that. There's a way to think about doing that, but to do that, what you need to do is you have to alter the capsid. So you have to put those peptide sequences outside the shell of the AAV. And whether someone's doing that and they work, maybe you're doing research and say, I don't know, it's not something I can profess great expertise with it. But when you mess around with the capsid, I guess the point is, when you start trying to fuse things onto the capsid, sometimes the AAV doesn't package right or it doesn't grow. So that's one comment. The other thing is there's ways that you can covalently modify the capsid. So you could take such a peptide and sort of stick it to the outside surface of the AAV and see if that helped. And again, when you do that, you alter the capsid and you can alter the properties of the AAV in vivo. So it is a good idea. It hasn't been the focus of exactly what we've been working on. We've been using natural capsids.
Okay, another question relates to advances in CRISPR and AlphaFold, which is a new publication about protein structure, and stem cell. Do we expect these therapies to develop more quickly soon? And specifically, the person is asking about in relation to cobalamin B. So comments on
for cobalamin B, yeah. For cobalamin B, we're very, very early. The first steps for that disorder are going to be to make mice and to use canonical gene therapy to just show that we can get it to work. What I can tell you that is for mutase type MMA. We have a paper we just submitted. I can't talk a lot about it, but we just submitted this paper last week using Cas-CRISPR editing. Not exactly to do what you've just suggested in your question, but we've used Cas-CRISPR mediated editing into albumin as a new way to treat, a different way, not using gene red, as a different way to treat MMA mice. It's very effective.
Okay, and then just a general question of when do you expect these clinical trials to begin, and in the US and also in Europe?
Okay, so I can't speak to, again, we're not a site for some of the trials that you might be looking up and that were mentioned. in other words, we're not at NIH, we're not part of that clinical trial. So I can't answer the question, I just don't know.
I'm told that a lot of them next year, first half of next year. So stay tuned.
And can I just add something about whether new technologies would allow us to get to would allow us to develop new drugs faster? And I think the answer is twofold. I think when you think about clinical trials, you need to think about two phases. One is the preclinical stage. That's the discovery stage. That's when you try to find new ways to make a new drug. And then the clinical trial itself. So all of these new technologies that can make things faster to discover a new drug. Yes, I think with new approaches, we can anticipate that it can shorten things a little bit. Once you get into the clinical trial, the science, regulatory science, is not so much determined by scientific discoveries, but it's a regulated process that is guided by the United States laws. And therefore, that part may not change too much because that part has to be fair, equitable, and safe, and should reveal the efficacy. But I don't think that part is going to change too much.
All right, thanks for your answers. So maybe we can move to cardiology. There's a few questions for Dr. Jordan and the rest of the panel. So Dr. Jordan, this one's for you. How is the cardiomyopathy and blood pressure, how are they interrelated, like high or low blood pressure? How do they interact with each other?
That's an important question that needs to be answered directly with your primary care doctor and your cardiologist, because there's so many different variables to consider. I can speak in general terms. Remember from my slides today that I talked about how many different things can lead to dilated cardiomyopathy. So even though the focus of our talk today is about propionic acidemia and the organic acid disorders and how they can play a role in causing cardiomyopathy, way more people out there have dilated cardiomyopathy secondary to undertreated or untreated high blood pressure, hypertension, or blockage of blood flow to the coronary arteries. So really depending on your age and your family history and other risk factors and the nature of the dilated cardiomyopathy and what your blood pressures are and whether you're having symptoms, your own doctor really needs to help decide how best to weigh these variables. And I'm sorry if that seems like hedging, but it's an important question, but it's a complex one that's hard for me to answer for your individual situation.
Thanks, Dr. Jordan. The next question is just about follow-up, cardiology follow-up. How often do you recommend, for example, a cblC patient go to get an echo? And this particular patient had one 2 years ago.
Yeah.
Just in general, you could speak, how often should people follow with cardiology?
With rare diseases, and the cobalamin deficiencies are no exception to this, we don't have a data-driven or evidence-driven concrete number to tell you with confidence, oh, if you have this every 12 months or once every 3 years. Let me tell you how I think about timing of follow-up for patients with medical complexity and rare diseases who are at risk for developing heart problems. If you have cardiomyopathy, and we know it because we see it on your echocardiogram, then it's easier for a cardiologist to say, I need to see you every 12 months or however frequent the cardiologist says. For people who are at risk for developing cardiomyopathy, I would say at a minimum, it makes sense in the cobalamin deficiency patient population that a a cardiologist looks at your child's heart at least 3 times throughout childhood, and then maybe once every 5 years in adulthood. And I say that not because not because I have a crystal ball where I know that a problem is going to happen, but we continue to learn and discover new things about these conditions. And these conditions are rare. And like I said, we don't have a good way of predicting who's going to have a heart problem and who's not. So even if your heart or your child's heart looks perfectly normal when they're a baby or 5 years old or when they're 15, it still makes sense to go and check in with a heart specialist periodically throughout your life. And then other non-cardiac factors that should lead us to want to look more often include things like neurodevelopmental or cognitive deficits, where maybe a person, even an adult in certain circumstances, may not be able to communicate if they're having symptoms. That might lead me to do things like just an EKG once a year, or but an echocardiogram less frequently. These decisions should be individualized and tailored to your situation. I hope that addressed the question.
Yeah, thanks. So the next question is sort of a clinical question too. If there's individuals who have a borderline long QT, is there anything specific they should be doing with medicines or nutrition or supplements?
Listen to your cardiologist is the quick answer. You definitely want to get, if your QT interval is in the borderline or prolonged range, that's a situation where you do want to take it seriously and get, in addition to your regular routine checkups with a primary care doctor, you want to make sure at a minimum you're getting a 12-lead electrocardiogram, the EKG test that I showed a picture of. And if you're in the borderline QT range, at least for children and young adults, I would certainly say once every 12 months, at least. There's also medications to avoid, but that's something that it needs to be done in consultation, in a discussion with your cardiologist.
All right, thanks. So this is a question for sort of the whole team, and it's a hard one. Are there early predictors or biomarkers that your child's PA will progress to affecting the heart, either by PCCA or B, or different types of mutations in the gene? Any comments? Maybe Dr. Oleg wants to comment on that.
Yeah, so I can start. So I think cardiomyopathy has been so far one of the hardest nuts to crack for us. I think, as we carefully examine the biomarkers, clinical parameters, looking into the possibility to predict the onset or the severity of cardiomyopathy in PA patients, it so far has been very difficult and very frustrating. And I think every time I feel like, I think we got it, there's one more patient who kind of, adds more information, and our entire prediction model kind of falls apart. So that tells you, we are dealing with a very complicated problem. So that's number one. Number two, is there anything we can do about this? And I think just like Dr. Jordan said, we could, by staying ahead of this problem by using, let's say, annual echocardiograms, you can stay ahead of the problem. And I really want to make it very clear is that I do not think the cardiomyopathy is a problem that starts in the third decade of life. We've seen cases where it can start in the first decade of life. And I think having a baseline echocardiogram is something that your doctor will be able to use as a baseline to compare, and just continue to follow echocardiogram perhaps once a year until we know things are kind of settled and are stable, and then educate yourself, talk to your doctors to educate you about the symptoms of cardiomyopathy, such as excessive fatigue, getting tired too soon, a shortness of breath, palpitations. Not every child will be able to tell you that because, they have difficulties with growth and development, so they may not know what it means when something feels funny in the chest. So, being very vigilant and just paying attention to those things would be important. I do want to make I want to share with you another observation. So far, I do not see a correlation, meaning that a relationship between the echocardiogram findings and EKG findings. In other words, we have seen patients who have prolonged QT, but the heart is squeezing really well. We have seen patients whose heart are not squeezing very well, but they don't have the long QT. So you can't use the EKG to screen for, you can't say if there's a long QT absent and the heart is squeezing just fine. Now, on the other hand, there are other changes on the EKG that you could use to kind of at least get a sense for whether the left chamber of the heart is enlarged, for example. So there are just other cues that doctors and cardiologists can use to screen for it. We think that there's another chemical in blood that can probably also be used to, get a better sense for how well the heart is squeezing, or probably, no, let me take that back. It's really linked to the size of the right atrium. That's one of the chambers in the heart. So and the chemical is called ProBNP, widely used chemical in adult and pediatric medicine. So this is something you can discuss with the doctors, and they can use that. That's yet another tool in their toolbox they can use to manage this condition. What I think is important is to emphasize that it's important to stay ahead of the cardiomyopathy in PA, so not to let it go, without any attention for too long. How to manage it is a different story. I think this is one of those situations where every child is going to be different. Every adult is going to be different. We're here to help. We're open for discussion, and we're very happy to answer your emails, get in touch with your local team, and have a conference call.
Thanks for that. The last question about cardiomyopathy is just that, have we ever seen cardiomyopathy in mice with PA?
I'm going to answer this in a measured way because I don't want to create any false hope. I think we have good reason to be hopeful about the use of mouse models in identifying dilated cardiomyopathy in our propionic acidemia mouse models. These are the studies that we have been doing this fall in the mouse imaging facility at the NIH. We have the tools and we have the team and resources to find cardiomyopathy in mouse models. And in some individual mice who have received the high protein chow and have similar genetics to some of our PA patients, we have seen some signs of cardiac dysfunction where that mouse's heart does not squeeze quite as well as another mouse. But the work continues to see if that is just an isolated mouse or an individual, or is it an effect of the anesthesia that we're using? Is it something else about the mouse background? These are all questions that we have the tools and resources to answer in the coming months and years. It is a work in progress, and I'm optimistic that we will find mouse models for cardiomyopathy, but I think the story is incomplete. It's still being written. Is that fair, Oleg?
Yes, that's very fair. Thank you so much.
So we're hopeful, but not quite there yet. Still working on that. So I think that was the end of the cardiomyopathy. So I'm going to just move to just some general questions about management. The first question is, we only do labs once a year. Should we be doing labs more often, especially when one med is removed? So this patient specifically has cobalamin C and carnitine was removed. So just some general comments about how often should the kids and adults be monitored with labs?
I kind of wrote back a quick answer to that question, and I will just say that, of course, it depends on every subtype, and it's very different for a cobalamin C patient versus all our more severe kids. The carnitine in the cobalamin C, now with the higher doses of the B12, our serum MMA levels in the cobalamin C children, young children, are very, very low. And I guess that could be a reason why the carnitine was lowered or removed if the levels were high in the blood. And yeah, follow up for carnitine levels, it would take a long time to lower in the blood. So I get the geneticist who suggested repeat labs in a year. That is totally fine, I think, in that specific situation. But as a rule, if things are the same and the treatment is stable and there is no trends that are worrisome in the metabolites, the geneticist decides how frequent the lab needs to be repeated. Every year is fine in more sick kids, or if there is a trend, a worsening trend, every 6 months or 3 months could be. In the kids with renal disease, nephrologists do labs every 3 months to monitor the doses and the medicines very carefully. So I hope that.
Great, thanks for that, Dr. Manoli. So the next question is, does the serum MMA level indicate anything, or is it just a number to track?
Again, I wrote a short reply in the Q&A. The serum MMA can be used in many different ways and is used in many clinics. It's not the most important for a day-to-day management lab. We try to say, we don't treat the MMA level, we treat the patient and the overall health of the child. But it helps periodically to monitor and track the trend of MMA. It is very different in the different subtypes again. You know, the severe MMAs will have very high levels, and they will go significantly higher in over 1,000, 5,000, 10,000. We have people with severe MMA and severe kidney disease that have extremely high MMA levels. At that stage of the renal disease, I think it is good to track those MMA levels to know, is it around 1,000 or is it 8,000? It makes a difference in how you plan the timing for the renal transplant or other interventions. And of course, it can be used for the B12 response, or, you know, there is many ways that we can use the MMA level. But I agree that it's not a critical lab to repeat every 3 months. It doesn't guide the day-to-day management for the children.
Thanks, Dr. Manoli. So the next question is for Dr. Oleg. Does the CO2 recovery rate look different from mild to severe PA?
The short answer is yes. And we'll leave it at that for now.
That's exactly what the isotope breath test we try to do, is to decide to split these severe versus mild forms. I kind of showed in the MMA, we have the severe cases have very low, very slow oxidation. Our control or milder MMA cases, they have almost completely normal oxidation rates. And when we give a liver transplant, the low oxidation is recovered back to normal. So it is a way to track that, the enzymatic activity.
Okay, another question about management. What are the indications for isoleucine supplementation, and can it be avoided by changing the diet? So that's for Dr. Manoli, I think.
Yes, that has been a big effort for our team and the community to try to get the children off the valine and isoleucine supplements. Isoleucine, valine, methionine, and threonine are the amino acids that make MMA or increase the propionic CoA production. So those are exactly the amino acids we try to lower with the management of MMA. So we have low protein and the special formulas that don't have those amino acids. So we don't want the kids to be on additional isoleucine or valine almost ever. So, and that can be monitored and achieved by changing the balance between the natural protein and the deficient protein, and by timing the blood draw in relation to the food. So if you have a blood drawn within like an hour or two after you have your medical food, the isoleucine and the valine will be very low, and 3 hours later it may be fine. So if you are careful about when to measure the amino acids and how to interpret them, most of the kids would not require valine and isoleucine supplements. And we have successfully weaned them off all their supplements, and with some, you know, adjustment of the diet and timing of the blood draws and careful monitoring with your clinics.
Okay, next question is related to B12 responsiveness. A baby was tested for B12 responsiveness and he didn't respond to the vitamin. Could that change with age?
So so the B12 response in a babies, and when it's done really early, it can be tricky because you need to give the injections every day and repeat the measurements carefully. And sometimes it is complicated by all the rest of the management that happens at the same time when people have IV fluids and protein and all that. So it's a hard thing to do in vivo, like to inject the baby and see if it responds in some situations. But if it is MAT0 patients, and nowadays we have genotypes and mutations that guide us for that. So we look at the B12 response in combination with the genotype in the patient. And if we think it's a MAT0 patient, that will not change with time. It will not happen that 5 years later you will start responding to the B12, because if you have that severe MAT0 phenotype with very little enzyme there, you cannot stimulate it with the B12 injections. So the test can be done in vitro in the skin, in the fibroblast cell, or in vivo. And if it is determined that you have a MAT0 phenotype, that will not change with time.
And then the second part of that question is, would oral methylcobalamin help?
And then, yes, I said oral, in general, oral B12 is only to supplement to avoid a deficiency in a kid. We have, all our kids are on very low protein diet. So we want to make sure that the serum B12 is not too low. And all our supplements and formulas and multivitamins that many kids get have B12 enough that you're not deficient. But comparing the oral medication to injectable medication is no comparison. All the MMA patients that respond to B12, they need injections. It's the oral medicine is not efficient. That is for cobalamin A or cobalamin C. You cannot, even with giving high doses of oral medicine, it's not effective. It has to be injectable. Yeah.
Thanks. Okay, is it possible to prevent recurrent pancreatitis? Can a low-fat diet help?
I don't want to monopolize, so if Oleg or Chuck want to chime in, I did write something in the chat.
Oh, of course, Dr. Manoli decided to say that. Yeah, okay, thank you.
No, I wrote in the chat, so I'll say what I said in the chat, that we have no...
Yeah, so I think if you ask 10 doctors, you'll probably come up with 10 answers. And that reflects the the uncertainty and the lack of effective interventions to prevent episodes of acute pancreatitis. However, I want to say that the general trend in the field has been so far not to modify the diet too much. So, again, it's just something that I'm seeing out there when I interact with pediatric gastroenterologists. I can't speak for adults, but I think the general field is I think high-fat diet is a very different story. But in a low-fat diet, I'm just not sure there's enough evidence out there to suggest that actually it prevents the episodes of acute pancreatitis. There are other risk factors such as extremely high levels of triglycerides. I'm not talking about 1,000 or more. I'm not talking about 200, 300, 400. There are other things. I think the severity of of MMA and PA is probably linked to the frequency of these episodes. There could be other what we call genetic modifiers that can result in the increased incidence of acute pancreatitis, such as being a carrier for changes in certain genes that have been linked to pancreatic episodes. So all of these things are very complicated. Here's what I would suggest. I don't want to give you a very vague answer to this question, but I think a consultation with pediatric gastroenterologists, if it hasn't happened, it would be important, especially if they are specialists or have a good understanding of acute and chronic pancreatitis. So I think it's just a good place to start. And then if there are additional questions that we need to get involved in these conversations, we'll be happy to do so.
All right, thanks, Dr. Oleg. The next question is regarding liver transplant. Is liver transplant indicated for a PA patient without major issues other than heart involvement?
I can take that question. So there are several reports and some private communications that we receive from other doctors that has been done. Let's say a clinical scenario would be a patient who is, I don't want to call some PA scenarios mild, although we know that there are some patients who just don't end up going to the emergency room with metabolic decompensations as frequently as other patients with PA, propionic acidemia. So we have seen scenarios where doctors recommended a liver transplant to patients who have been more or less stable. Did not have to, they didn't have to be at the hospital too frequently. Maybe went without a hospitalization for 2 or 3 years. But their heart, the contractility, how well the heart is squeezing, began to decline. And doctors recommended to do a liver transplant. Now, after the liver transplant, I don't think that the recovery is instantaneous. It takes time for the heart to recover. Think about this. This is one of the organs that's just constantly squeezing every single minute of our life. There, at 60, 70, 80 beats per. So it takes a long time for the heart to recover. But do we think that this is a cure for cardiomyopathy in PA? And I would want to say no. I don't think that it's a cure. So every single patient will have their own unique clinical situation. I don't think one size fits all. I cannot make any blanket statements about, yes, everybody with cardiomyopathy needs to get a liver transplant ahead of time. I think every patient is individual and it needs to be discussed individually. It may not be a good fit for some other patients. So here's just the bottom line. It needs to be discussed individually.
I would add to that, I agree with everything that Dr. Oleg just said, but I would add to it that remember, these are rare diseases. And while we have a large cohort at the NIH, most cardiologists practicing out in the community either will never see these diseases or they may see them once in their entire career. And they may not think of the organic acid disorders when they find a new case of dilated cardiomyopathy. And there are case reports in the literature of patients whose propionic acidemia is identified because they were found to have dilated cardiomyopathy, and then a very careful clinician ordered some additional metabolic tests to find, oh gosh, they have this unexplained acidosis and they have some of the other biomarkers of PA, and a diagnosis is made that way. The other comment I'd make is, these case reports of patients' heart health improving after liver transplant in some case reports. There's also case reports of people's hearts getting worse after liver transplant, in full disclosure, to mention that, because that's also, there is a case report published from last year from Boston of that unfortunate outcome. But it also, it harkens back to the important concept that these organs, that the abnormalities are not happening in isolation from each other. Improving liver health or maintaining kidney health helps your heart health. And by making the liver healthier, you can protect the heart. And so that is another reason why it's important that your cardiology team is not just aware, but has some understanding of how the kidney and liver function are connected to heart function in the organic acid disorders, if you can find that type of cardiologist in your community.
Thanks. I have just a couple more questions in the chat that I thought would be important. So the first is probably for Dr. Oleg. Should adult patients with PA have cystatin C levels measured instead of relying on the eGFR and BUN creatinine for evaluating kidney function?
Yes, I would definitely agree with that statement. I think, in pediatric patients, especially in the first 10 years of life, I'm just not sure it's that critical, although it's very important to get a baseline. When you want to compare apples to apples and oranges to oranges. So getting a cystatin C based estimate of renal function is important. But I agree with this comment that as patients get older and as they approach the end of the second decade of life and enter their third decade of life, and in other words, they're in their early 20s, that would be very important to use both, probably get one and the other. So the creatinine normally you get as part of electrolyte check. So it's just part of a standard part of the evaluation. But cystatin C is a separate test. Let me take a step back. Maybe not everybody knows what we're talking about. So we're talking about a way to measure kidney function, how well the kidneys are doing their job. And the kidneys have lots of different functions. But one of the more important one is to clear the toxins. And it's important, especially for patients with organic acidemia, since the liver cannot do that very well. Then a lot of this burden is shifted to the kidney. So the kidney have to filter it out and excrete it, put it outside of the body. So they have to carry this extra burden. I think that's one of the reasons why the kidney decline happens faster in patients with organic acidemias. But to measure the kidney function directly is a very difficult thing. It's not something you can just walk into the hospital and say, like, hey, I just need to get this test. It's a hospitalization. Lots of things have to happen. We can do it at NIH, but we don't routinely do it. And other doctors can do it as well, but don't routinely do it. But you can use what we call estimates. In other words, you can come as close as you can using the chemicals that are floating in the blood, and because they are filtered by the kidney, you can kind of get a better sense for how it does. So there's one chemical that's called creatinine, and the other one's called cystatin C. These are two different tests, and doctors have to order them separately.
Okay, Dr. Manoli, this one's for you. For cobalamin C, should there be protein restriction? And is there anything we can do to protect her eyes?
Yes, so I did make the comment about the formulas that are definitely contraindicated in cobalamin C, and that we don't want to restrict the protein because the kids need the methionine, especially in the very early stages of brain and the development. So the young children, babies, we do not want to protein restrict at all. Many clinics give extra methionine supplementation and aim for a high level of methionine during that early phase. Now we do need the kids to learn about protein restriction, because eventually, despite our high concentration of B12 and giving them 20 and 30 milligram every day, the patients will eventually outgrow even that high dose, and then they have high homocysteine and higher MMA values. So for the long-term health of their children, they need to stay as close as possible to the recommended daily amount of protein rather than, so it is important to educate for the healthy protein amounts rather than the usual 3 to 4 times the recommended amounts that the American diet will frequently be. So some protein restriction, especially in older patients, will be needed to keep the metabolites in check, because we cannot give huge amounts of vitamin. I don't know if that's clear.
That's great. That's great.
And then what was that second part, right? Just protein or?
No, oh yeah, of just what can they do to prevent the maculopathy, the eye disease?
Unfortunately, that is our difficult, the hardest question, and one that we did not think there was a way. That's why we were so encouraged and so surprised, and that we were able to see those 3 or 4 people that are to date known that have severe early onset cobalamin C and had high doses as babies really early on, from the first month or second month of life, that had much less eye disease. Now, with those very small numbers, we do not know if we will prevent or slow the progression of the eye disease in a good number of the cobalamin C cases. And as I mentioned, many of those manifestations start already in utero, like before birth. So some kids are already severely affected before they're born. It is really a very difficult aspect. We were hoping for our gene therapy that we could maybe target the eye and provide some gene therapy effects. And Jen has led that effort in the mouse models. I can speak to that, Jen. So we are working on ways to directly target the eye disease, treat earlier in the hope to prevent and delay it.
Okay, thanks, Dr. Manoli. Dr. Venditti, one question for you, and then we have a couple questions about COVID at the end. So I can't find the exact question, but the question was something about our mRNA therapy. Because it's so fast acting, could it be used in a metabolic crisis?
Yeah, I typed the fast answer. The answer is yes. I don't know that there's any clinical trials proposed for that indication.
Okay, great. Thanks for that. And then just a few questions about COVID. How has COVID affected patients with OAs?
So go ahead, Oleg. Yeah.
I can start. Let me put it this way. We are very worried about our patients, especially in a combination of COVID-19 in the context of any chronic condition is going to be not a very good combination. So we are very worried for you, and we would like you to, to avoid it as much as you can. So that's in a nutshell. How exactly it's going to play out in real life, we don't know. And frankly speaking, I don't want to think about this, but I think we need to think about it as a case of bad flu. And just like we know that bad flu, in PA, MMA, it's just not a good situation to find yourself in. That's the first thing I want to say. On the other hand, I know how difficult it is for all of us to be away from our friends, to not see our loved ones, our immediate family, our extended family, and how difficult it is. And, we lose our support network, people that we love and who support us, especially in our circumstances. So how exactly to find that balance, safety, and, be part of your community, be part of your family is going to be unique and different for every one of you out there. But if I could just say one thing, please be safe and stay safe and try to avoid this virus as much as you can.
And everyone should get the COVID-19 vaccine. Is that recommended?
Absolutely.
That was the next question.
Yes.
That was the next question.
And
the families wanted to know exactly, are there any concerns about the vaccine with the MMA, OA kids? And when a vaccine is available, will you make a recommendation for which vaccine should they take?
So,
well, I think it's kind of hard to let me step into this discussion. In fact, actually kind of fielded that question yesterday from one of our friends in the Zoom meeting. I think we want to be cautious about, offering blanket recommendations. And I think the reason for that is because we are waiting for FDA to approve it. It has not been approved in the United States. We need to know publicly available information on the safety and efficacy. So once that information becomes available, we'll have a more detailed conversation. Now, I am personally, and I'm speaking only for myself, I'm not speaking on behalf of the United States government or NIH here. I will be strongly considering getting it myself, because I think it is not only to protect myself, but this is part of my contribution to protect my community, my neighbors around me, to create what we call herd immunity. So I think I need to be part of this. This is our contribution. So how exactly it's going to play out, let's just wait. And, we're not that far away from, I think the meeting, the 10th of December. And I think we can have a more detailed conversation, but I'm sure there are other opinions out there, other measured maybe opinions out there that I think are just as equally valid.
Irini, do you have something?
Yeah, no, I was trying to say that at this point, it's not approved for the children yet, so we will have to wait for those studies. But for the families and the older population, we strongly recommend everybody to get the vaccine. I don't think that one vaccine versus the other will be particularly dangerous or different for the MMA or Cobalamin adults, let's say, until we get to the children. I think we will follow the guidelines from the NIH and the CDC, and when the vaccines come out. I wanted to say for so far, our younger children and the younger population has not had a significant incidence of very bad outcomes with the COVID-19, just went in a kind of more positive note, including patients who had renal transplants, and we were more concerned about them, or patients with high homocysteines and kidney transplants, we were also concerned about them more. But so far, because our population is younger and they are not, they're old age, diabetes, secondary other factors that make COVID-19 particularly dangerous don't apply to the very young children, and many of them had a milder course of COVID-19. But vaccination is critical for the family members, for going down in the age groups. We will start with the parents and grandparents, and the children will be later on in that priority list. But if the vaccine is as effective as it is reported and safe, despite the complications that we know can happen with fever and local reactions, that's all out there. We're all following those very carefully. But like your flu shot, it's going to be part of our life to get back to our normal activities. Yeah.
I would like to add two comments. One, the International Society of Heart and Lung Transplant does publish a dashboard with data, and pediatric heart transplant patients have had slightly higher rates of more severe symptoms than the general pediatric population, but it's not, the numbers are not staggering or terrible to the extent that, early on in the pandemic, with our worst fears, to put yourselves in or some of you are the parents of children, and young people on immunosuppressive regimens, imagining what that stress must be for you each day to carry that burden. We're here to talk about with you. But the second comment I'd like to make is about the systems and our resources. And when hospitals are at or in excess of capacity, especially patients with chronic disease who rely on access to healthcare resources, are a challenge. So yes, we want you to stay safe and we don't want anyone to get sick with COVID, but it's also important for communities to pull together and practice social distancing and hand washing and mask wearing and all those things that our public health experts are recommending, so that the healthcare system has the available resources to provide the emergency care when children are having acute metabolic crises and other issues where they have to use the hospital system for reasons other than COVID.
Because there was a note here in the chat, yes, a kid with a severe PA cardiomyopathy can have a very severe course of COVID-19, and that is the underlying disease in combination with the virus. That is, of course, a serious case. But the cardiac, Chris covered that part. So.
Yeah.
So I think that was most of the questions, unless Kathy, do you have any additional?
No, I am, we're at 3 hours here, and I really appreciate you guys spending this much time with our families today. And I can't speak enough good things about the NIH, and I hope that our families can come and visit if they haven't already. And hopefully next year we'll be back visiting for your studies and participating, because obviously it's very important. It really, we really appreciate all the work that your whole team does. So be sure to share that with everyone. And I speak on behalf of all of our families. Keep up the good work. And again, thanks again for speaking with us today, and be in touch. We'll be all in touch.
Great. And I put in the chat our contact info in case, you know, I might have missed a few of the questions. So feel free to email me. And if you're interested in following up on the study or inquire for the first time, I put Susan's email address in there. So feel free to contact us.
And we did record this, and so we're gonna make it available for any families that weren't available to speak or to join us today. And I appreciate, again, all your work in the field for organic acidemias. So thank you so
Stay safe,
much.
everybody. Thank you so much for your time.
Thanks.
Everybody.
Thanks.
Thanks.
Great to
Bye.
see you all. Bye.